we are organizing a congress in Acapulco. Acapulco Beach, I think, is a very beautiful place to know. This course is going to be from on 5-6 November. So if you have a possibility, if you could join us, you are welcome here in Acapulco Beach.
Thank you, Victor. I think I've been to Acapulco. It's one of the nicest places. And thanks to Elvis Presley, who gave the Fun in Acapulco movie. You have to go and watch it. And the diver is coming from top, and getting a retinal detachment. It's an amazing place. Nature is unbelievable. Food is wonderful, and people as well. So I hope. Hi, Pablo. Unmute yourself. Okay.
Welcome, Pablo.
Okay.
Hello, Pablo. Nice to see you. Hope to see you here in Mexico on November. If you could join us.
I would love it. I think I will not be able to, but I will give my best to let you know.
Chandra, I want to ask you for permission. You see, this each faculty will have 15 minutes plus 5. I think we'll omit this 5 since we are going to have discussion toward the end of each session for almost half an hour. So with this, people can, if they want to catch up with Keki's conference or meeting, they can still go and join him. So we'll be about 10 or 15 minutes earlier, if it's okay with you.
Should be okay, but I have kept that 5 minutes margin because most of us don't really finish in time. So
okay. But we'll give them the presentation, the 15 minutes.
The other thing was, the discussants are all, I mean, they would only discuss, or would they show some case? That was the other option. So,
okay. When I correspond with them, I said, try to focus on the presentation and make the discussion accordingly. Otherwise, we could have included them in the program and they put their case presentation. So this was the deal with them. And I think one of them...
No, I think if we can be on time or if we can finish early, it is fine. So
okay,
we'll go along with that. No issues.
All right. So we still have 9 minutes time. I'm seeing Matthias. Hi, Matthias. Unmute yourself. Okay, good to see you.
Hello. Good morning. Good afternoon to everybody.
Okay. What is the time now in Argentina?
The time now is 10 a.m. 20 minutes past 10.
This is civilized time for you, but I'm sure by the time we finish for India will be too late, isn't it?
It will be dinner time or
dinner time,
time to sleep,
yes.
Really.
Yeah.
They're still kind of locked down. 10 o'clock, the whole city closes.
Wow. No, here in Saudi, they start now. Today or yesterday was the National Day. People were celebrating on the street. No social distancing because the number of cases has diminished tremendously because they reached this almost 70% vaccination, full vaccination. And the cases becoming much less. Death from corona, I think, daily in the range of 5 to 6, which is very small. And they are planning the 3rd dose, the booster dose soon. I think they will start. American, they start, I think they approved it just 2 days ago. How is in Spain, Pablo, vaccination?
I think it's almost 80%.
80%, well, very good. 3rd dose, is there a plan for booster dose?
Well, they are discussing and they are waiting for the European agency to make it clear because this European Union is fixing the rules and probably next week they will decide who is going to receive the third dose and when.
So Vladimir must be with us shortly because he asked for the program. And I hope Moody will be with us soon, isn't it?
Yes.
Imad, can you mail out the latest version of the program? I can't find it on my new computer here right now. I apologize.
You want me to send it to you?
Yeah, that would be excellent.
Okay.
I think that we need to rename to Victor because there is a mistake with the name.
He's Ramesh.
Yes.
I can fix it, Victor, on this side.
Yeah, it's always
I think
the
that
same.
with the last Zoom occurs the same.
That's probably because Victor is using Ramesh link, maybe. Victor?
Maybe, but
Yeah, this is usually a situation if somebody share his own with others. We discovered him immediately. You
Thank
get
you,
it?
Matthias.
you're welcome. We have 15 minutes, really, for the lecture?
15 minutes, yes. We are
Excellent.
talking about the 5 minutes if you finish on time, but we still have discussion toward the end of each session for half an hour for the 3 or 4 talks.
Great, Ayman.
Yeah, but if somebody wants to give a comment, of course, we are, after all, in one family, we can waive things. It's not
Oh,
written
okay.
in stone and rigid. Hi, Ramesh.
Hi, Matt, and hi, everyone. Hi.
Are you using Victor link? No, I'm just kidding.
No, I think Victor is using my link.
Yeah, you gave it to him one time, perhaps.
No, last time also and this time as well.
Will we be starting in time? I think we have 5 more minutes.
5
Okay.
more minutes, yeah.
Thanks, Chandra.
We have changed a little bit the names. Dr. Boji has apologized. He has something to do, so we took his name from the program as a discussant. I see Dr. Venkatramana. Hi, Dr. Professor Venkatramana. Hello. How are you? Good to see you. First time we meet on a webinar.
Good evening, Venkat.
Good evening, Dev Pujari. Hi, everybody.
Hi, good to see you. Where are you based, Professor Venkatramana? Where are you based?
Venkatramana is based in Bangalore.
Bangalore, yeah. This is the Silicon Valley of India?
Yeah.
Yeah.
Correct. I don't know, India's done like 750 million vaccination, but we are still
Short.
like halfway mark.
Aiga.
Hello.
Hi, Igor.
Hi, Igor. Good to see you.
Nice to see you.
Nice to see you too.
Hi, gentlemen. Hello.
Hi, Vladimir.
Hello.
Vladimir.
Hi, Vlad.
Good afternoon, Vlad.
How are you all?
Fine. How are
Everything
you?
okay for everyone? Victor, hello. Imad. Chandra,
Good to see you. Yeah.
Pablo, good to see you again.
Good to see you.
Hello.
Matthias.
Hello,
Hi.
Vladimir.
Ramesh, our Indian boy.
Sanjeeva.
From the
Hi, Sanjeeva.
Falls.
Unmute.
Hello,
Hi.
Sanjeeva.
You?
Sanjeev. Sanjeev.
Sanjeev.
Great. Heck.
To remind Moody, I think.
We're Moody, I think, just give him a reminder. We have 2 minutes more. Vladimir, I just mentioned that we might possibly skip the 5 minutes after each presentation because we have a discussion toward
At
each
the end.
session.
Okay.
And to satisfy Keki because he has his webinar. It was
I know. The
unnoticed.
collision is unpleasant, but unavoidable.
I
I
apologize.
did mention that, Imad, when this was circulated. I did mention this possible there might be a clash.
But Professor Chandra just mentioned that he did not commit his date when he communicated with him last week.
Okay, I think it can happen, so I don't think we need to worry too much about it.
No. Andrea and Thomas, hi.
Good to see
Good
you.
afternoon,
Yourself, Thomas.
Andre and Thomas.
Wonderful. Okay.
Hi, Tom.
Yeah, you already spoke about that clash, and I told Kiki that this time I said I knew this one here before I knew the date of his one. So it's a matter of
organizing.
First come, first serve. Yeah.
We still, I myself, I go and join him once we are done here as well. We do
Oh, absolutely! It is always very nice, and it is it's a learning experience, to be honest. Yeah.
I see Moody here, but Moody oblique.
Moody is there. You just need to change your orientation, Moody.
He's yeah, turn the camera. That looks better. That looks better.
Doing some acrobatics there, huh?
All right. We see you.
Now better.
Unmute yourself. We could not hear you. Yeah.
Hey, Ramesh.
Hey, Woody.
Hey, Vlad. Nice to see you. Nice to see you.
I think we are full house. If you
a good company today.
Also, Chandra, should I go ahead and proceed?
Yes, please.
Well, welcome everybody from overseas, from the 5 continents, and all the faculties and members of the 2 committees. This webinar was initiated on a nice initiative from Professor Chandra Sheikh Dubidara and Professor Qureshi to collaborate with us, Professor Benish and myself, and it was a wonderful. This is not the first time. And I think we are going to joint venture this together as moderators. So they will be divided in 2 sessions. Welcome all the speakers. We have Professor Matias Baldocchini from Argentina. We have Professor Victor Hugo from Mexico, Professor Daniel Roy Daniel from Switzerland, Eka Kaspar from now Boston, US, Pablo Gonzalez from Spain, Professor Ramesh Nair from England. We have somebody, he left his chair. He's coming back. Professor Igor Lima from France. Of course, Professor Vladimir is known to all of us. He is co-chairing the Neuroanatomy Committee. Professor Sanjeeva from England, and Professor Thomas Santarius from England, Professor Andre Guttenhaus from Holland, and of course, Professor Moody Qureshi, who's co-chairing the endoscopic committee from Kenya. So we'll start, I think, without any further ado, we'll start with the first presentation of Professor Matias. Go ahead.
Good morning to everyone. I am happy to be in contact with so many friends in this morning from Argentina and afternoon for several countries. Thank you very much to Professor Vladimir Benz and Ahmad Kanan, our co-chairman and chairman of the committee. Thanks for the invitation and congratulations for this proposal to Professor Chandrasekhar and Professor Mahmoud Qureshi, and thanks for this kind invitation. I will talk about the anatomy of the lateral ventricle and approaches to the lateral ventricles. Maybe most of the attendants is familiar with the anatomy of the lateral ventricles, but as Professor Roton said several times, anatomy needs to repeat in order to keep the knowledge in our mind. This beautiful dissection and this drawing is part of a publication about approaches to the central cord that we publicated with an important group of neuroanatomists from several countries some time ago in the journal World Neurosurgery. And for study the anatomy of the lateral ventricle, it's important to remember that in the top of the brainstem, we have the thalamus, this important nucleus located in the lateral, in the right and left, in the left and right, sorry, mesencephalon. And this important nucleus is surrounded with several structures in a C shape, in a curvilinear shape over the surface of the thalamus. Here we have the caudal nucleus with the head, body, and tail of the caudal nucleus. And here we have the fornix, that it is important the relation between the fornix and thalamus, because through this important relationship is formed the choroidal fissure. And this anatomy is very, very important to learn prior to study the lateral ventricles, because this structure forms part of the surfaces of the lateral ventricles. In this beautiful dissection from one of the co-authors of our work, Richard Párraga, we can observe the left thalamus. Here is located the pulvinar of the thalamus with the ventricular surface and the cisternal surface located medially to this part. And here we have the caudal nucleus with the head of the caudal nucleus, body, and the tail of the caudal nucleus. And here we have the fornix. The fornix have a C shapes finished in the mammalar bodies, and then turns to posteriorly and from medial to laterally, forming this important structure that is the choroidal fissure, very important for understand the anatomy of the lateral ventricles, the vascularization of the lateral ventricles, and of course, some kind of approaches through the lateral ventricles. And here finish near to the hippocampal formation inside of the temporal horn of the lateral ventricles. The lateral ventricles have a C shape surrounding these structures, as I told you, and have a posterior prolongation that sometimes could be important and sometimes could be small. This is the frontal horn. We have the occipital horn. The frontal horn is anteriorly. We have here the central portion of the body of the lateral ventricle. The atrium, this is an elongated segment of the lateral ventricle. The occipital horn and the temporal horn is located in this portion. The lateral ventricles, the left and right lateral ventricles are separated through in the midline through a membrane that the name is the septum pellucidum, that it's located between the anterior branch of the fornix. Here we can observe the fornix, and this is the foramen of Monro, and superiorly it adheres to the inferior surface of the corpus callosum. The corpus callosum is form parts of the roof of the lateral ventricles, and not only the roof. If we consider in that segment the anterior portion of the ventricle or frontal horns, the corpus callosum forms the roof, the anterior wall, and the floor of the frontal horn of the lateral ventricle. Here, a beautiful dissection showing the lateral projections of the corpus callosum, where we can observe that it's forming the part of the roof of the frontal horn, the body, the atrium, and not only the atrium, because we have here a lateral expansion of fibers that the direction is directed to the temporal horn, and that covers, this is the tapetum fibers of the corpus callosum, that covers the lateral wall of the temporal horn. These structures are very important to remember because form parts of the lateral ventricles. In this sagittal section, at the level of the corpus callosum, we can observe this is anterior, this is posterior, and here we have the thalamus, we have here the fornix, and this is the caudal nucleus with this important structure, bigger, that is the head of the caudal nucleus, the body, and then turning the direction to the temporal horn. Here we have another beautiful dissection, and it's important to remember that the study of the lateral ventricles, for a proper comprehension of the lateral ventricles, it is important to remember this structure that the name is the brain central core, or the central core of the brain, because some of these structures form part of the walls of the lateral ventricles. Here highlighted is the lateral ventricles in all the extension, the frontal horn, the body of the lateral ventricle, the atrium, the occipital and temporal horn prolongations. This beautiful drawing from the Roton's books, it is really didactical, because it's represented the different walls of the ventricles in the different portions. Here we have the frontal horn, the body of the lateral ventricle, the atrium, and the temporal horn. The frontal horn, we have in the roof, superiorly in the frontal horn, we have the corpus callosum, and in the floor is exactly the same, because the rostrum of the corpus callosum, as we observed some minutes ago, turns and form the anterior wall and the floor of the frontal horn of the lateral ventricles. And laterally, we have the head of the caudal nucleus. In the middle section, we will find this membrane that is the septum pellucidum. Sometimes when we perform surgeries inside of the lateral ventricles, or when we need to reach tumors located in the third ventricles, an important technique, endoscopical technique, is the fenestration of the septum pellucidum in order to connect both lateral ventricles. If the patient could develop in the future hydrocephalus, it could be preventive in order to connect the lateral right and left ventricles. Here we have a representation of the body of the lateral ventricle. In the floor we have the thalamus. In the floor and the lateral wall, we will find the body of the caudal nucleus, and in the superior part of the body of the lateral ventricle, the corpus callosum, exactly the same. And in between the medial wall and the inferior wall, we will find the fornix with the medial part of the fornix, and starting the posterior part of the fornix too. In this C drawing, we can observe there a representation of the atrium. In the atrium, we will have the superior part and the lateral part is covered by the fibers of the corpus callosum. The floor is formed by the collateral sulcus in inferior surface of the brain, and form the collateral trigon, and the medial surface or the medial wall of the trigon. We will have this important structure. This is the forceps major and the calcar avis. This is the bulb of the forceps major and the calcar avis in the atrium. It is very important, this relation with the tapetum, and here we have important fibers that the name is stratum sagittale. And we need to remember, we need to know in order to avoid the lateral accesses to the atrium. And here, the representation of the temporal horn. In this beautiful dissection, we can observe the foramen of Monro, anteriorly the frontal horn, the body of the lateral ventricles, the atrium, and the temporal horn. This structure that is inside of the lateral ventricle is the choroid plexus that extend from the foramen of Monro to the inferior choroidal point, very important structure that we will find inside of the lateral ventricles. Here is the choroidal fissure represented, and this is the calcaravis and the bulb of the corpus callosum in the atrium. Here we can observe a beautiful dissection of the lateral ventricle in the temporal horn. This is the hippocampal formation inside of the cavity of the temporal horn, and this is the inferior choroidal point and the fibers of the optic radiations covering the fibers of the tapetum that form the lateral wall and the superior wall of the lateral ventricles. If we divide the lateral ventricles in the frontal horn and in the body, we can observe a medial surface and a lateral surface. The vascular structures that are in the lateral ventricle are very important, especially in the point of the foramen of Monro, because there is an important vascular connection. We have here the thalamus-straight vein and the anterior septal vein. In this point, this vein joins to form the internal cerebral vein, and it is very important to recognize during endoscopical or microscopical surgeries of the lateral ventricles. In this beautiful endoscopical vision, we can observe the anterior branch of the fornix. This is the foramen of Monro. This is the choroid plexus entering to the foramen of Monro in order to form part of the roof of the third ventricle, the anterior septal vein, and the thalamus-straight vein. This is an important vascular relation when we perform surgeries inside of the lateral and third ventricles. The approaches to the different parts of the lateral ventricle are represented in this drawing of Rotton's book, very, very nicely representations. We have different approaches depending of the location of the tumor. We can enter through the interhemispheric fissure. We can enter through superior longitudinal frontal sulcus. Different approaches depending of the location of the tumor. If we have a tumor located in the anterior, in the frontal horn, we can access through the lamina terminalis. We can access through interhemispheric homolateral approach. If the lesion is located in the midline, it's comfortable to perform interhemispheric homolateral approach. And if the tumor is located laterally, we can improve the angle of attack to the tumor doing an interhemispheric contralateral approach. The posterior transcallosal approach is an approach that could be performed, but remember that the fibers of the corpus callosum it should be preserved in the posterior part in order to avoid the disconnection syndromes. The interparietal sulcus is an excellent approach to access tumors located in the atrium, transsulcal occipital for tumors, rear tumors located in the occipital horn, and transtemporal. The temporal horn is projected in the surface of the lateral, in the lateral surface of the brain, in the middle temporal gyrus. Here we have a beautiful case from Pablo that we published some time ago, a subependymoma located in the anterior, in the frontal horn that was resected through an interhemispheric contralateral approach, as we can observe in this MRI of control. Another surgical case, this is a huge cavernoma located in the anterior, in the frontal horn that was resected through a transcortical superior frontal sulcus and was resected totally. This was a huge cavernoma. In this case, we have a huge meningioma located in the body of the lateral ventricle that was approached using the superior frontal sulcus, exactly transsulcal approach. We can access transcortical or transsulcal. We prefer to use the transsulcal for these huge tumors. This is another case of a central neurocytoma that was resected using the interhemispheric anterior transcallosal approach. This is a short video showing how this natural corridor provides us a beautiful access for this kind of tumor located in the frontal horn in the body of the lateral ventricles. It's necessary to separate the pericallosal arteries, recognize the fibers of the corpus callosum, and then we need to dissect the fibers transversely, and then we will find the exit of cerebrospinal fluid, and we can start to work with the tumor coagulating the surface. This was a central neurocytoma, a very vascularized lesion, and we can remove the total lesion through this interhemispheric approach. And with this approach, we avoid to damage the cortical surface and the subcortical structures too. For these cases, it's very useful the use of these micromirrors, angulated micromirrors, in order to check the proper resection of the tumor. This meningioma was located in the atrium and was resected through the interhemispheric sulcus approach. This was a similar case. This was a tumor, huge tumor located in the atrium, and it is very important to perform sometimes preoperative embolization of this tumor in order to avoid deep bleeding during the resection. Another huge meningioma located completely in the atrium and part in the occipital horn due to the growing of the tumor. And in this case, we select the intraparietal sulcus approach. This is an interesting route, a microsurgical route to access to the atrium in this case. This is the video. It's important to recognize a sulcus that is parallel to the midline, and you need to remember that the interparietal sulcus ends in the post-central sulcus. This is why we need to work posteriorly and not so anteriorly in order to avoid lesions on the post-central gyrus. We work here, performing the bulking of the tumor. This was a tumor that prior was embolizated in order to avoid the bleeding in this deep location, and the tumor was resected in several pieces because it was really huge, this meningioma, intraatrial meningioma.
1 minute, Matthias, 1 minute.
Yes. The atrial location is the most common location of the intraventricular meningioma, due that is located in this sector, the most important amount of choroidal plexus in the atrium. Here, the last part of the resection of this intraatrial meningioma, and the last part resected in one piece. Thank you very much for the invitation, and
Thank you, Matthias.
Very much.
We might give one comment if anybody wants to have a question or comment. Otherwise, we keep it for the discussion. Yes.
Yes. Can I just ask you, you showed this case of the neurocytoma coming in, I think, transcallosally into the body of the lateral ventricle. Do you use navigated ultrasound aspiration to make an appropriate estimate of the depth of your extent of resection? Because I think coming in from the top down to a tumor like a neurocytoma that grows into the thalamus or the structures laterally is so hard, to find out how deep can you advance without violating the next structure, especially for an intrinsic tumor. Do you have any recommendations there?
Thank you, Professor Eckhart Kasper. I have operated 4 central neurocytomas. This is a rare tumor, and I didn't feel comfortable in any cases working in the deep part of the tumor. Due to our economical situation, we didn't use near navigation for this kind of resections, because I operated in the public system of our country. But anyway, I think that in the last part of the tumoral resection, where the tumor is near to the surface of the thalamus, if we programmed our neuronavigation system, I think that the coordinated could change due to the cerebrospinal drainage and the structure. We are removing part of the central neurocytoma, and the thalamus is in part reaccommodated in their proper location, and it's really complex to know where is the tumor and where is located the cells of the thalamus. Yes, it's complex.
Thank you. Thank you. I think now we dive from the Pacific Ocean to the Mediterranean. We come from Argentina to Spain, and we dive into the third ventricle with Professor Pablo Gonzalez.
Now you can hear me?
Yes.
Okay, so let's go a bit deeper, and thank you, Matthias. We have discussed the first and second ventricle, so let's go to the third one, and which are the key anatomical points in order to optimize our approaches. It's obvious that the third ventricle is located in a deep position, it's completely encased in neural tissue, and it has a variable shape and size. So these are things that really make our decision quite difficult about the approach. And I always like to be very simple about naming the approaches we can use for a single region. So we have basal in this case, anterior through the lamina terminalis, anterolateral through the foramen of Monroe, posterolateral through the choroidal fissure, and posterior through the pineal area. So which are the important parts of the third ventricle we must be aware of? The entry from the lateral ventricles, which is represented by foramen of Monroe, the exit, which is the aqueduct of Sylvius, and we have a floor, which is given by the midbrain, and also the anterior wall, given mainly by the anterior commissure, lamina terminalis, and the chiasm. Finally, we have a roof, which is given by very important vascular structures as the telacoridea and the internal cerebral veins with the posteromedial choroidal arteries. And we have very important also lateral walls given by the hypothalamus and thalamus. Finally, the posterior wall is mainly represented by the pineal region. So let's start with a single case. This is a tumor, 16 years old lady who had this tumor located in between, let's say, the lateral and the third ventricle, which is clearly obstructing the foramen of Monroe, which is the entry from this right lateral ventricle to the third ventricle, causing this unilateral hydrocephalus, so which is the optimal approach. So obviously the optimal approach is that one with which we feel more comfortable, but if we apply these concepts from Professor Yazarkil, we should follow an anatomical corridor, try to perform an atraumatic manipulation. That's why we place these patients in lateral position, and then trying to release some CSF in order to open the fissure and reach this area of the junction of the third and lateral ventricles. So finally, in this case, we decided to go contralateral because this ventricle was bigger than the other one, than the left one, so we could have much more space to check the foramen of Monroe opening or the compression. So this is how it looks like after splitting the fissure. And this is the maneuver we start with, releasing CSF from the supracallosal system. Then we apply a couple of cottonoids on both sides in order to keep the fissure open. Then we try to identify both pericallosal arteries, and in between them, we split the fissure as Matthias has perfectly explained. We try to follow the transverse direction of these fibers, but somehow we will finally create a bigger entry through the callosum. Then we use the endoscope in order to make sure that we are in the correct place. So this is the septal area. So this is the choroid plexus, and as Matthias has explained, it's entering through the foramen of Monroe, which means the foramen of Monroe is somewhere near here, and this is a tumor which is, as you can see, completely closing this foramen of Monroe. And so then we start devascularizing this tumor. And finally, we check again how our decompression is doing. Now the foramen of Monroe is much more evident. The choroid plexus is right there, which is open. And we use this drain in order to make sure that we don't have any trouble. But this is the post-op in which, with this approach, we can see how the foramen of Monroe is now open, which was indeed the main goal. So how we can translate these three concepts of the anatomical corridor, automatic manipulation, and preserving the surrounding structures to the neuroendoscopic procedures into the third ventricle. So it's important to understand the eloquent cortical regions we should avoid as an entry point, as Matthias has explained. We should understand the cerebral substance we are going to traverse. And it's very important to understand the tumor biology and the attachment to the ventricular surface, and obviously, which is the goal of surgery, which is not only resecting the tumor, but most of the cases we have to try to reestablish the CSF circulation, like in this case, in which we have this tectal glioma, which is compressing and closing the aqueduct of Sylvius. So in this case, we have 2 points of pathology, the anterior floor, where we want to do a third ventriculostomy, and the posterior wall, in which we will probably want to take a biopsy. So this is the anatomy seen from behind, in which we can see the floor of the third ventricle with the tuber cinereum, which is the place where we will be performing our third ventriculostomy through the foramen of Monro. And this is the area of the tectum just posterior to the aqueduct, in which we want to take a sample. So in this case of third ventriculostomy, this is how we plan it. We first of all fix our target in the floor of the third ventricle, then we go to the foramen of Monro, and finally, tracing a line in between these 2 points, we will have the ideal cortical entry point, which should be somehow quite close to the coronal suture. So it's important to identify all these 5 structures in order to plan our surgery. So this is how we enter with a cannula, and then we introduce the scope, and once we're in the lateral ventricle, we try to get our orientation. But it's very important, I always try to reinforce this point, that when we are working with this neuroendoscope, we have some blind areas, which is represented by the yellow, in which we have the working channels and the light source. And this is an area which is blind for our eyes. That's very important to understand. So let me show you what I mean with this. This specimen in which I am entering the lateral ventricle directly with the working channel, and I'm breaking and damaging the fornix because I cannot see the upper part of the endoscope. So this is the correct way to do that. We introduce first of all our cannula in the lateral ventricle. When it's located there, we introduce the scope, and we are much more aware of all the blind areas. So now we go back, checking where the tip of the cannula is passing through. And once we are in the third ventricle with the cannula, we can introduce the scope to the tip. So this is a good trick in order to try to avoid damaging hidden areas. We don't have a mirror, but we must be aware of what's going on behind us. Look at this guy. His target was reaching his house, and he decided to go through the more direct pathway. He reached it, but he caused a disaster behind. So that's the idea. Try not to cause a disaster behind you. Once we have reached the third ventricle, we will try to identify the tuber cinereum. This is a good paper in which some landmarks are given by this rhomboidal part from the stalk attachment to the point in between the mammillary bodies. In the midway, we will find a good area, but we must always be aware of the relative location of the basilar tip. Once we create our stoma, we must make sure that both liquid membranes have been perforated. So that's why we should go inside and check these pulsations. We can check it also in the post-op MRI, as we have flow through the stoma. And that's all about the anterior part of the floor. So let's go to the posterior part of the floor. This is a lady who has some gait disturbances, headache, personality disturbances, and several memory problems in the last weeks. So what we can see here is a mesencephalic ependymal cyst, which is located in the posterior floor of the third ventricle. So in this case, we can solve the hydrocephalus just creating a third ventriculostomy, but in this case, we decided to try to penetrate and fenestrate this cyst. So for that, again, we need a different trajectory because the area we want to reach is right here. So which is the goal of surgery? We want to reestablish the CSF circulation. Probably we want to do an endoscopic approach. And our plan is first of all to try to do a cyst fenestration or an endoscopic third ventriculostomy. So in this case, I did both. I started with the endoscopic third ventriculostomy, and then I went to the cyst, which is the ideal trajectory for the cyst. So we want to cross the foramen of Monro and have a direct trajectory to the area in which we want to do this fenestration. So this is the anatomy where we will be watching. So we enter through the frontal horn, we identify the choroid plexus, and we follow it till the foramen of Monro. And with this direct trajectory, we see the interthalamic adhesion and the posterior part of the floor of the third ventricle. In this specimen, we can have a look anteriorly and posteriorly, and finally we will see the aqueduct right here. So this is the anatomy we should be aware of, and this is the entry point. In this case, we did this single incision in order to have a bar hole for the endoscopic third ventriculostomy close to the coronal suture, and one more bar hole much more anterior in order to reach the frontal horn, foramen of Monro, and posterior part of the third ventricle in one single trajectory. So after the third ventriculostomy, we went through the anterior trajectory. I'm showing here in this MRI. We enter the frontal horn. This is the choroid plexus. This is the interthalamic adhesion. Same thing we saw in the specimen, and this is the point in which we want to fenestrate this subependymal cyst. We open slightly. This is the surface of the third ventricle, so that's why we want to be very, very careful in this area. And then we go inside the cyst in order to make sure that there is not a tumor there. There is no tumor, it's a clear, very clear cyst. And with this maneuver, we were able to decompress the pressure. And you can see how we created this stoma here. And now the circulation is reestablished through the stoma and also through the aqueduct of Sylvius. So this is how we can take advantage of the anatomy. This is a case from Professor Roy Daniel from Switzerland. I want to share it with you because it's showing a cavernoma which is going in the wall of the third ventricle. And in this case, it is an ideal cavernoma in order to be treated through a transcallosal posterolateral route through the transchoroidal fissure. So see, this is the opening of the interhemispheric fissure. This is a posterolateral route. So this is a transcallosal transchoroidal approach. So here we do have the pericallosal arteries. This is where Professor Roy has done the callosotomy in order to reach the lateral ventricle. And then we have to identify the choroidal fissure. This is the tenia fornicis. So this is the fornix. And these are the internal cerebral veins. Once the dissection is completed, we can see even some branches of the posterior medial choroidal arteries right there. So this is the anatomy we must be aware of in this transchoroidal approach. And then we directly access the lateral wall of the third ventricle in a very nice way. So this is the anatomy, again, after the removal. So how we can reach this lateral wall of the third ventricle, taking care of the vessels in the velum interpositum. So this is Roy. He's teaching me a lot of neurosurgery, but I must say that I'm teaching him some cooking skills, and he's cooking some paella there in Lausanne. So let's go to the last two cases. These are two different patients with the same pathology. This is a colloid cyst, and this one came with GCS7. That's why he had in the middle of the night an emergency bilateral EVD. This one came with headache and memory problems. So we decided to do an elective endoscopic removal, which is the anatomy we must understand about these colloid cysts. They are growing mainly in the anterior part of the roof of the third ventricle, quite close to the internal cerebral veins, so the junction of the thalamo-septal veins and just posterior to the foramen of Monro. So this will give us a clue about which is the best approach, again, quite anterior in order to have direct view and good control of the anterior third ventricle roof, and good control of the choroid plexus, which is a structure that could potentially bleed. So this is the entry. With the endoscope, we start coagulating. It's part of the choroid plexus. We try to cut it. I'm not a very fan of this approach. I'm not very good with it, but we decided to do it because it was a small one. So in this case, we start coagulating and cutting the choroid plexus, and then we start pushing gently the choroid cyst after having cut it. And then we have this bleeding, which is very uncomfortable, but with irrigation, and even if we localize where the bleeding is coming, we can even use the Fogarty in order to stop that bleeding. So this is one of the approaches. And a couple of weeks later, I had this case in which I decided to do the same, but suddenly we had some technical problems with the endoscope, so I had to reconvert it. And this is really true. So through the superior frontal sulcus, I tried to reach the frontal horn. So this is the same trajectory, different technique, because it's a bimanual technique with which I felt much more comfortable. We have the bipolar. We can empty CSF in the lateral ventricle, so the bleeding is not so annoying. We open the capsule of this colloid cyst, we remove the mucous contents of it, and once it's quite debulked, we can easily manipulate it and even have control with two hands with a microscopic microsurgical technique of the contralateral choroid plexus. So then we can take it, and this is the aqueduct of Sylvius, so you can understand how anterior this trajectory is being. This is the same route, but different technique, bimanual technique, with which you can see that the surgery was a little bit more easy. So this is the post-op, no problem with both cases. You can see how a microscopic transfrontal, we have this clear sign, but the same one with the endoscopic, so no problems at all. Posterior wall, we can have pineal region tumors. In this case, we have to perform a posterior, purely posterior approach, so we must be aware of the pineal region area, limited superiorly by the splenium and inferiorly by the pineal gland. So we can go medial, purely medial, or even better, going a little bit paramedial in order to avoid the midline veins. This is what we are doing right now, moving a little bit more lateral in order to have control of the midline veins. So we start dissecting, coagulating, debulking, and finally we go inside the posterior wall of the third ventricle in order to coagulate the most anterior parts of that tumor. And then this is the view we have after removing the tumor. We can have a nice view of the posterior aspect of the ventricle with both foramina bone row on that side. So many different routes, many different names, but clearly the anatomy is key. So it's important to know not only the inner, but also the outer shells of the third ventricle to try to optimize the choice of the approach based on anatomical understanding. And don't think that endoscopic and microscopic techniques are enemies, because surgery is not a battle, and they are fantastic weapons in order to deal with these lesions. Thank you so much.
Thank you, Pablo. We allow one comment or question. Ramesh?
That was very nice, Pablo. This one comment, it's not a question, it's one comment about one of those cases. I think it's probably the first case. There was a tumor near the genu, or near the transition between the lateral ventricle and the third ventricle, and used a contralateral approach to access the enlarged right frontal horn. I wonder whether I would have done the same thing, because there's a tumor which is on the right side. Possibly there is a risk of damage to the right side internal capsular area, and if you're trying to retract the opposite hemisphere, you may have an additional side effect from retracting the contralateral side, especially if there's a cortical damage or a retraction of the draining vein. But your case went very well and it was successful, so I suppose you can't argue about success. So I don't have anything else to add, but I'm sure it's something which is a completely a traumatic way of dealing with tumors. But I have this concern about doing contralateral approach for a tumor which is affecting the other side, which is a risk of causing the opposite. In effect, you can have bilateral weakness if you have a complication from it.
Thank you, Ramesh. I put many things on the balance before deciding if IPSI or contralateral, and I didn't mention all of them, but there is something also very important, which are the bridging veins, and I'm not seriously very dogmatic about that. Whenever I see a good window in between veins in one side, I decide to go through that side, and that was the case in this one. But I fully agree with your comment, and I thank you.
This is a very valuable comment, Pablo, about the bridging veins. All right, so I think I will give over to Professor Modi Qureshi. He is a professor at Aga Khan University from Nairobi, and he's going to introduce the next speaker as a moderator and conduct the coordination of the three discussants of the papers. Professor Modi? Modi. All right. Dr. Qureshi, are you with us?
I don't see Moody right now.
I don't see Moody in it.
Okay, so I'll just proceed to introduce.
You can probably continue, Iman.
Yeah, introduce Professor Thomas Santarius from England. He is part of this committee, very active colleague on the Neuroanatomy committee, and he's going to dive further to the posterior fossa and give the anatomy of the fourth ventricle. Thomas? Are you there?
Can you see my slides?
we can see the slide and we can hear you.
Now you can hear me, yes.
Apologies,
I
guys.
myself.
The
So
net
I'll
just
start again. Thank you.
froze
Thank
on
you,
me
Per.
just as I was about to introduce myself. But nice to see
Moody
you
is
again,
there.
Thomas. So please go ahead. Sorry about that.
Thank you very
Just
much.
before he starts, Moody, you are going to conduct the coordination of the discussion toward the end of this session.
Sure. Thank you.
Iman has kindly introduced me, and so after the third ventricle comes the fourth ventricle. So that's some logical progression here. Oops, is it moving?
Yeah.
Okay, so that's the bar right in the middle of my screen. That's better. So we talked about third ventricle, and to get to fourth ventricle, we go through aqueduct. I'm supposed to cover fourth ventricle and aqueduct, but I'll start with the fourth ventricle and then leave some time for the aqueduct later on if we have. So essentially, we want to know how to get to the fourth ventricle, and so let's talk about what the walls of it are, as we have done about the lateral and third ventricles, so as we can determine how to best get into it. So the fourth ventricle is a floor, and as you know, there are lots of important stuff in the floor, and that's the kind of a schematic representation of it. Essentially, floor will never be the entry into the fourth ventricle unless we have some very unusual lesion that will simply create a corridor for us, and I'm yet to see one like that. Then we have a lateral walls and a roof, and the lateral walls are made of peduncles, and here we can see in the upper part of the fourth ventricle the superior cerebral peduncles, and the superior cerebral peduncles are then continue with the middle cerebral peduncles and inferior cerebral peduncles. It's going to be a little bit confusing, but this is actually a very good picture that shows the middle cerebellar peduncles here, the inferior cerebral peduncle here, and the superior cerebral peduncle here. So just to be kind of clear, that's the input mostly from the higher level of the CNS. Inferior cerebral peduncle is mostly input into the cerebellum from the lower level of the CNS, and superior cerebral peduncle is mostly output. It's not quite as simple as that, but it's good to think of it like that as a rule of thumb. The roof, the whole fourth ventricle, as you know, is tent shape like, and it sort of slopes up to ascends to the apex called fastigium, and it has therefore the superior part and inferior part. The superior part is kind of has neural tissue in it. The inferior part is membranous, and therefore, as we will see, is a very good place to enter the fourth ventricle. As we've seen on the superior lateral part of the fourth ventricle, we have the inferior and lateral to it, the middle, and here the superior cerebral peduncles, and in between the superior cerebral peduncles is the superior medullary velum. Velum is a veil, so it's a kind of cover which is spread between the right and left superior cerebral peduncles. So that's another picture of it. Superior cerebral peduncles here, superior cerebral peduncles here, with a velum in it, spreading all the way up to the fastigium, which is the apex of the fourth ventricle. And here we can see the inferior medullary velum, which is similar to it. It pretty much spreads between the inferior cerebral peduncles and also the lateral recess. Essentially, it is the connection between the nodulus and flocculus. So you probably are familiar with nodular floccular lobe of the cerebellum. So the midline, the vermian part is nodulus, the hemispheric part is flocculus, and the part that connects it is the inferior medullary velum, which has some neural tissue, but the neural tissue has no function. So here is worth bringing in some embryology and coming up from the very basics. And the basics being that we have a neural tube with the central sulcus, or the central cavity, or central ventricle, you could say. And as you know, the brain undergoes growth of tissue in between in some areas. There's atresia going on, and there is bending, and so on. So, but essentially the organization is always such that around the central cavity we have ependyma, and on the outside we have pia, and the pia brings vessels, and in between we have various degrees of neural tissue. Somewhere like in the telencephalon there is lots of neural tissue. In some other areas, such as we discussed in the inferior medullary velum between the flocculus and nodulus, there is a small amount of neural tissue, and in some areas there's atresia goes on, and there's absolutely no neural tissue, where the ependyma is in direct contact with the pia, and the pia brings vessels, and when this happens, we have a choroid plexus. And also there's lots of sort of bending going on, particularly around the rhomboencephalon, and it helps with stretching of the neural tissues, and particularly in the midline and lateral aspects of the rhomboencephalon, we then have entire perforation of the neural tube. So there's not only that there is no neural tissue, but there's not even ependyma nor pia, and there's direct communication of the central cavity in the outside. Therefore, we have the foramen magendi draining directly to the cisterna magna, and we have foramina adushka draining into cerebellum medullary and cerebellopontine cisterns. And here you can see a foramen of magendi, and then you can see the tila choroidea, where the pia is in direct opposition to the ependyma with no underlying neural tissue. If we go further up, we have some neural tissue in the form of a inferior medullary velum, as we've seen before, and that's the nodulus. So there's tonsil, nodulus, and if we follow the nodulus into lateral recess, we eventually see flocculus in the CP angle. So let's have a look how the approach is done, because this is the perfect place to enter the fourth ventricle. But before we go there, we need to sort of understand pica. We need to also understand that pica is one of the most variable arteries. And essentially, I put the medullary segment of the pica in red, because this is where the pica is sending branches to the brainstem. So we have anterior, lateral, and tonsillar medullary segments, and the tilovelar tonsillar. You have to not take it completely as a gospel, and look very carefully where the vessels go and what sort of branching they have. Occasionally, you will have a branch going to the medulla, particularly to the area of the sort of superior, sort of inferior cerebellum peduncle can be fed from the tilotonsillar part of the pica. So again, the vertebral arteries, the basilar and the pica, can be extremely variable, but essentially from the didactic point of view, we want to think of the anterior, lateral and tonsillar medullary segments. Now, in terms of positioning, these are not sort of perfect pictures, you know, you would like to have a little bit more flexion in the atlanto-occipital joint, but the first maneuver is open the suboccipital space by not just necessarily flexing the neck, but first of all, you want to flex the atlanto-occipital joint by opening the space between the C1 and the foramen magnum. So by simply flexion, and then you want to further bring the head down so that you have comfortable way of looking at the floor of the fourth ventricle. So schematically, it is pretty much done like this: flexion at atlanto-occipital joint, then further customized flexion of the neck. They want to bring the head up, ideally even above the chest. We want to strap the patient, and you want to position the patient in such a way that it's comfortable to work if you want to go forward. The higher up you want to work in the fourth ventricle, the easier it is to work along the axis of the body. So again, schematically, again, we don't need to the axis of the fourth ventricle. We don't need to make such a massive craniotomy all the way up to the transverse sinus. Something like that is probably sufficient. I usually do this sort of incision. It may be necessary, particularly in ependymomas and so on, to go lower down. So we may either do a laminoplasty of C1, or we can just basically cut some of the C1 or undercut some of the C1, depending what we need. You always try to be minimally distractive, and then simply spread the tonsils, and then we can see the tonsillar medullary and tilovelar tonsillar part of the pica, with the nodulus in the middle, and of course foramen magendi and tila choroidea. So we can then cut the tila choroidea all the way up, and then inferior medullary velum as well. And if we just keep cutting it like that, that's the inferior medullary velum, usually kind of milky color. And eventually we can then freely lift the tonsils and the inferior part of the roof of the fourth ventricle, and we have absolute motorway all the way up to the aqueduct. Now, of course, this was on a specimen, but this can be done on a patient as well. 48-year-old lady with this sort of subependymoma, enlarging the aqueduct. You can see there's a massive aqueduct up there, and she was heavily symptomatic. Initially, we done third ventriculostomy, so some of the symptoms improved, but she still required removing the tumor because it was actually growing and increasingly causing her more and more symptoms of the local compromise of the structures there. So here is top of the head, feet are here, and we are separating gently the tonsils. Then we bring them apart, and simply you can see the, of course, foramen magendi. You can see the tila choroidea. So we just coagulate and cut and systematically work upwards, keeping the pica laterally. So any of the vessels, the choroidal vessels, we can cut. That there is no blood supply to any important brainstem structures from this part of pica. These are all choroidal vessels, so we can divide them and cut with no problem. And we do this on one side. We do this on the other side. I think the computer is struggling a little bit. Just give it a moment to catch up. So again, we can see tila choroidea, defined vessels, buzz the choroid plexus, buzz the choroidal, and then you can start seeing the milky inferior medullary velum. Again, we can cut it because there's no functional tissue in it, and we can bring it all the way up to the lateral recess. So we then change orientation. Now we are looking from feet upwards. You can see the stria medullaris of the fourth ventricle of Piccolomini, and here is our tumor. And we're just working on the tumor, separating it from the surrounding brain, whatever sort of works best, whether it is mechanical traction as we're doing here, or using ultrasonic aspirator further down. And now tumors coming up. There's a little bit of it left around the aqueduct. In fact, some of it is in the aqueduct. And you can see the habenular. But actually, no, here you see the posterior commissure, and here is your aqueduct. And we are removing the last bit of tumors, and of course you can see the CSF coming from the third ventricle, and this is obviously much bigger aqueduct that you would normally see due to the hydrocephalus that was generated. Now, this is the other side of aqueduct, the sort of tumor that Pablo was showing before, and this is a tumor that could be taken endoscopically through the left foramen of Monroe with the endoscopic simple suction or endoscopic cues. Unfortunately, we don't have that, so we did it open method, and again, I just won't go through it because Pablo showed it. So essentially, it was interhemispheric approach. We are now lifting the fornix, opening the choroidal fissure to properly enlarge it. We're going to buzz and cut the anterior septal vein, which will allow us to elevate the fornix. And we are now dividing the velum interpositum in between the left and right internal cerebral veins. And this gets us nicely to the hemorrhagic low-grade, to turn out to be hemorrhagic low-grade glioma. And after it's removed, you can see the cerebral aqueduct from the third ventricular side now, from the other side of it. So we're just moving on. That's post-operatively. Now, sometimes, occasionally, you have tumor that is based in the aqueduct of Sylvius. So this was a crazy sort of case where it initially presented with tumor in the fourth ventricle, third ventricle, lateral ventricle, and so on. And we went and did ETV and biopsy of it, and it turned out to be, as you can see, a rosette-forming glionural tumor of the fourth ventricle, so grade 1 tumor. Now, given the full extent of it, we decided to treat it with radiotherapy, and probably I wouldn't recommend it anymore. This was quite some time ago. And this led to absolute massive necrosis of the tumor in the fourth ventricle and aqueduct of Sylvius with, as you can see here, that's basically cut and paste from the operative note. Not only this dramatic scans, but also dramatic neurological presentation, eventually with GCSO3 and bilaterally fixed and dilated pupils. So I just went, telovelar and basically sucked out everything. All the necrotic tumor in between. The lady survived and actually made decent recovery, but certainly remained disabled. So occasionally you have a massive tumor in the aqueduct as well. So aqueduct itself is of various length, usually about 15 millimeters. Kind of normally the width of it varies widely. And we need to be aware of all the very important structures around it. So, pineal gland is not necessarily important structure, but the structures around it are habenula, commissure, posterior commissure, and from posterior commissure is pretty much the aqueduct there. Tectum, we often associate tectum with inferior collicular, meaning auditory center, superior collicular, meaning the visual processing, but tectum does much more than that. We are yet to learn much more about tectum as a center of integration, not just tectum, but also together with tegmentum, integration of movement of the eyes, positioning of the body, coordinating vestibular body position and visual and auditory sensation, but also other somatic sensations. So we need to be very respectful of the tectum.
Thomas, you are 2 minutes above beyond the time.
Okay, and I'm pretty much done. I just wanted to highlight the fact that the very important structures around the tectum. On the floor of the fourth ventricle, we have all the connection that are important to coordinate gaze, that are leading all the connections are coming to the oculomotor nuclei in the broader sense, right in front of the aqueduct. This is all integrated with the output from the cerebellum, which are the superior cerebellar peduncles that cross in front of the aqueduct, and so on and so on. Guys, cross this one, actually skip this one. I just wanted to highlight all the very important structures that surround the aqueduct. So we ought to be very respectful of it, whether we operate from the fourth ventricle, third ventricle, and in it. Apologies for overrunning, and thank you very much for your time.
Thank you very much, Thomas, Professor Thomas Anterior from the UK. A detailed lecture on the various technical aspects of the approach to the fourth ventricle. I don't see any questions. Are there any comments that anyone has put? I don't see any on the chat.
I suppose I should have said that there's also transvermian approach, but essentially, as we try to operate through natural spaces, this is virtually never
May I then ask
required.
one question, Thomas? You have described most of the approaches to the aqueduct, from the top. Is there any consideration that you would consider approaching the aqueductal lesion through the fourth ventricle?
Oh, yes. For example, the cyberpendymoma, was in the aqueduct, and because it was mostly situated at the distal part of the aqueduct, it dilated the aqueduct. So yes, you can. It really depends on what one wants to do and where. But yes, it's definitely
basically if we have a dilated fourth ventricle and dilated aqueduct, we could probably do it safely.
Yeah.
But
we have to be very mindful. We have to be very mindful of everything that is around the aqueduct.
Andre has a comment.
Yeah, because it is, of course, it is an approach through the foramen of Magendie, through the fourth ventricle, but that was an open approach. Have you ever tried to do a purely endoscopic approach from the occipital side?
No, I have to say, I'm so well rehearsed because I do also pediatric surgery. Well rehearsed the open approach that I simply haven't done it. No, but I'm sure you have. So perhaps you could share with us your experience briefly.
No, it depends a little. You can do that if the lateral and third ventricle are small. especially I refer now to cases with, let's say, trapped fourth ventricle. And you nicely can do that purely endoscopically through only opening the atlanto-occipital membrane and then move through the foramen marginale to stent the aqueduct, which otherwise, if the lateral ventricles are large, then I do it from above to also can do an ETV. But if they are small and completely collapsed due to shunting, you can do that. I have to be honest that I only did cystic lesions in the fourth ventricle, never tried to remove a solid tumor from the fourth ventricle through the endoscope. No.
Actually, I have to say we have done it as well, saying this. When we had isolated fourth ventricle, we tried to, with stenosis of the aqueduct and shunt supratentorially, we went endoscopically through the dilated fourth ventricle, and then dilated the aqueduct and left a catheter with extra holes, both in the coming from the surface, including the fourth ventricle, through the aqueduct and third ventricle.
And just telling the people that what I did wrong in the 90s was only stenting the aqueduct with a 4 or 5 centimeter piece of catheter. And I found them all a few months later in the lumbar sac. So that's not something that you should do. You should, if it is from the front, you fix it to the burr hole. If it is from here, you fix it to the fascia.
Yeah, that's what we did. Yeah, that's the fixation point.
That's an essential point for doing that. Otherwise, you spoil an otherwise good operation.
But Andrew, tell us briefly about your experience with these Torklitzen type shunts and the eye movements. You know, everyone that I've spoken to that has placed shunts into the aqueduct as a physical shunt, they reported the eye movements were all over the place afterwards. So I've completely abandoned any foreign body in the aqueduct as such, because I think a minimal stretch in this location has maximum effect or side effect on the brain. Just 2 comments.
No, I fully agree with you that the so-called aqueductoplasty, and then especially if people use a Fogarty balloon, we just heard nicely that the aqueduct is 50 millimeters long. It's a longitudinal canal.
Yeah, it's too wide.
And then you take a round Fogarty balloon and try to dilate that to do an aqueductoplasty. Those patients will not look nice afterwards. They look this way to you. And nature is mild. Some of them will recover after months. It takes long, but not all of them. And that is not because we did it so well. We did it awfully. So actually what I learned, I always borrowed, well, I grabbed them simply from my cardiology colleagues, the longitudinal stenting catheters. And that was nicely to do, and then only briefly do that. But in the case of a trapped fourth ventricle, when you come from below, this edifice is rather wide, so that you can easily do that. And of course, it should be a short tract that is closed, preferably a membrane that is closed. If the whole aqueduct over 50 millimeters is blocked, there is no way that you can open that. Of course, you can open it without any damage. You will damage that, absolutely. Absolutely.
I would like to join. I know we are running out of time, but this is very important to actually cover this, because Andre, opened this, and it's such an important sort of topic. I would be also extremely reluctant to do any dilatation of the aqueduct for aqueductal stenosis. Yeah. I think aqueductal stenosis, where the problem is upstream, really needs to be solved upstream, i.e. either ETV, ideally, and it also works in shunt or whatever. But the fourth ventricle, isolated fourth ventricle, dilated fourth ventricle, people have such terrible symptoms. And pretty much there's just no solution to it. There's no good solution to it. So if one can, let's say, connect the fourth ventricle to the third ventricle and the supratentorial compartment and drain it that way, that would be pretty much my only indication for kind of stenting of the aqueduct, and one has to be very much aware of the risk. Use very tiny catheter. I wouldn't do any dilatation. I would just put, a small catheter that would just fit there pretty much, or minimally dilate and connect the fourth ventricle with the third ventricle.
Thank you very much, Thomas. Just as we're getting ready to get on to the discussion part of this, just your thoughts on the use of the cavitron in some of these tumors that are going into the aqueduct. Any tips or any precautions, any cautions that you might want to advise?
Unfortunately, I don't have it, so I can't say, but in principle, I'm a big fan of it.
I'm a big opponent to it. I think anything in the fourth ventricle and in the aqueduct should not be touched by a cavitron. I think that's a crude device, and you cannot, a millimeter that has gone in the wall of the fourth ventricle and the floor is a disaster in terms of side effects. So I'm a huge fan of open. You see everything. You have much better control over the bleeding sites and so on. But I do have a different question to Pablo, if he's still there.
May I comment on this cavitron issue, Mahmoud?
Yes, please.
I think I am a fan of cavitron when it comes to decompression. It is a marvelous value. But the way you use it, the oscillation should be not very high when you come near, and you don't use it to the last bit of the tumor. You leave a margin of capsule. This is where you use the microsurgical technique to peel it out. But the central part is a marvelous tool, and we use it for any type of tumor.
And you'd still use it in the aqueducts, tumors
No,
of the
in the aqueduct, no. I will go in the tumor before the aqueduct, and then I use a dissector and then mobilize this one microsurgically.
Great. I think we've overshot our time, and I think the discussions are waiting. We're going to have three very eminent case discussions from Professor Ramesh Pirolos, Akat Kaspa, and Venkat, I see, is also waiting in the wings. So we're all set. Professor Ramesh, are you there to start the case discussion?
I don't see Ramesh, Carollo. I don't see them. Just move to the others, and you can.
Yes, Professor Akat Kaspa, you're next.
Yeah, so I want to briefly ask Pablo a question about this case of the subependymal cyst that was in the midbrain, and you went in and fenestrated that cyst after you did an ETV. So maybe you can give us first some advice, especially people that are not as good with the endoscope, really doing an ETV in a full prepontine cistern that is like already compressed, to me is scary. Do you have any good strategies telling people how to avoid that if the prepontine cistern is small and the pons is plastered against the clivus, to not injure the basilar? That's one thing. And the second thing is this subependymal cyst, could have also been simply drained into the ventricle by putting in a Ricken catheter stereotactically. So you don't need any endoscope. Your axis would have been somewhat smaller. I'm sort of becoming increasingly a fan of minimal invasive procedures where I don't put any big instruments anywhere. And you know that from a recent talk I gave on pearls on internal shunting. Have you thought about stuff like this for a subependymal cyst that sits on the brainstem?
Well, thank you. About the first question, indeed, in this case, the prepontine cistern was quite wide enough, but this is one of the contraindications for ETV, to have a very severely compressed prepontine cistern. And in that case, we really try to avoid doing an ETV because the successful rate is extremely small and we can create terrible complications. So in those cases, we try to avoid doing the ETV. But in this case, the prepontine cistern was wide enough.
I think Andre has something to say. I presume, I'm pretty sure he wants to say the same thing I want to say.
No, because I'm not agreeing with you, Pablo, in this, that there is some plasticity here. And what you do, of course, you can't open properly the tubus cinereum in front of the mammillary bodies then, but there is one very important technical thing here. You open the floor of the third ventricle on the dorsum sellae. So that's the part, because that is a safe part. It will not bleed. You even can take a scissor. You can take even a grasping fork. You open it on that bone,
navigation.
on the bone. And then I take a little hook and bring that initial opening a little bit backwards. And then you will immediately see that it starts pulsating, and then the room opens up and you have more space. So that is the way how you can do that. And therefore it is not, in all fourth ventricle tumors, that's not a contraindication for ETV, at least not for me.
Yeah, I was right there. Andre said exactly what I thought he would say, but because essentially we always approach the ETV slightly from posterior to anterior. So we will kind of always, I mean, it depends where we put the burr hole, but generally we kind of face or direct it on the dorsum of the sella. So rather than, on the basilar, and certainly not on the basilar posteriorly where the perforators come from. So yeah, it is a fairly safe maneuver.
I think we're going to move on. If we can move on to Professor Eckhart, Kaspar, with your case for discussion.
No, I just, that was my question.
Okay, because...
All right, may I have one comment on what's said on the previous case and the stereotactic puncture of the cyst. Stereotactic, we used it frequently, but when it comes to structure near the midline and long track, this is a very safe procedure, but sometimes you might hit one of the vessel and you turn your life in catastrophe. So I think viewing this where you are going to puncture the cyst, it's of value when you are doing anyhow the third ventriculostomy, and then you have the scope just to move it a few angles and you are on the cyst wall safely and without puncturing any vessel or veins that can cause your trouble. So stereotactic is not without problem always, and we always try to avoid it around the midline structure.
Also, the cysts come in sort of different forms and shapes. We had one that had a very thin layer, pretty much only a ependymal layer posteriorly bulging into the tectal cistern. So we approached it supracerebellar and made a hole in there, and at the same time made the posterior third ventriculostomy.
Venkat, have you got something that you wish to discuss in the case presentations?
Yeah.
So are you going to share your screen?
I would like to comment on the stereotaxy. Yeah, stereotaxy, I would like to comment. It is a blind thing. So you have no control on hitting the vessel, as well as there is a problem on you can have no control on the size of the opening as well. So the risk is that it might fail. So I will try to share the screen now, Qureshi.
Sure, sure.
Can we close that previous one?
Anybody's, we don't think we have another presentation.
Yeah,
is there a presentation? No, yeah, we can. There we go.
I have a case presentation, but
sure.
I'm not able to share. Screen share.
We're only seeing your inbox.
You are sharing your screen, just that you have to open your presentation.
Yeah, we're seeing your inbox, so your screen is being shared.
You need to minimize your mail, Venkat, and
can you see this now?
No, we're seeing, yes, now we can see it.
Yes. Can you now?
You can go on to presentation mode then.
Yeah.
The full screen presentation mode. Yeah, perfect.
Can you see now? Yes. This is a 6-year-old boy. So this is a 6-year-old boy presented with this symptom, and he's always been nodding his head in the classroom. So all the children started ridiculing him. So that's the symptoms with which he is diagnosed. So it's a bobblehead loss syndrome. And when we did the MRI, this is the picture like. He was 6-year-old when I initially screened him with an MRI. So MRI shows there is a large arachnoid cyst, which is prepontine. And you can see that the cyst wall is lifting the third ventricle, the third ventricular structure is almost close to the corpus callosum. The brainstem is completely pushed posteriorly, and of course still the aqueduct is still seen, though not looking functional, and along with the fourth ventricle. So shall I continue, or you want to discuss this at this stage? What would
Any comments from anyone?
And what is
I mean, this is sort of, I know it's a recognized entity with arachnoid cyst bubble dot head syndrome, but I just often wonder what the underlying mechanism for them nodding the head all the time with this big cyst in the head. I don't know what the reason is.
Bilateral compression of the putaminal region.
Oh, I see.
They say that's the background. I published on that about 15 years ago, and but this is a huge one. This is a huge one, Fenka.
So we did a endoscopic transventricular ventriculocystonostomy, and post-operatively, as you can see the picture, post-operative, the brainstem started taking into a normal shape, and the ventricles have been opened. Both, you can see both the cavities there.
Venkat, you have to increase your sound. Come closer to the mic if you can.
Sound now. Now, am I audible?
You're audible, but your voice is a bit low.
You can see the pre-op and the post-operative scan.
On your computer, you have to put the loudspeaker louder.
Yeah. Is it better now?
Yes.
Yeah.
Okay. So you can see the you can see the ventriculocystocystonostomy, which is done communicating to the prepontine area, and the brainstem is regaining its shape, displaced slightly anteriorly compared to the preoperatively. But the child did extremely well after that, both in the school, and the bobblehead has stopped. No abnormal movements of the head. He grew normally 10 years. And 10 years down the line, he came with these following symptoms. He's become obese, has got several endocrine deficiencies, and physical and mental milestones were normal. He had a very good scholastic performance, and endocrinologist has shown a lot of hormonal disturbances along with the hypothalamic disturbance, like a little bit of memory disturbances. So at this point, we would like to discuss that arachnoid cyst, though we think it is benign, but it can have a lot of neuroendocrine disturbances, including the hypothalamic disturbances. Now, the debate was that whether the floor was damaged during the surgery, but I think the hypothalamic floor was damaged much more with the cyst itself and the long-standing pressure, probably. And
currently, the arachnoid cysts in suprasellar arachnoid cysts are classified in 2 or 3 groups. None of them actually describe that the cyst goes down right into the prepontine space, right up to the foramen magnum, as has been shown in your case. Any comments on that from
The only comment I have to make in that respect is the suprasellar cyst we see quite commonly. They arise in the suprasellar cistern itself. But in this case, I presume it's probably below the iliacus membrane or even the interpeduncular cistern, then
Absolutely.
went upwards.
I mean, most of the cysts which go into the prepontine cistern right up to the clivus are supposed to be benign, and they don't deform the brainstem as much as we have seen in this case. So,
yeah.
So the question that comes to mind is whether the distal part of the arachnoid cyst was actually adequately perforated, because it seems to go right down towards the medulla, and one wonders whether there is still some part of the cyst of the arachnoid wall that is still patent. So, or were there two separate arachnoid cysts? One of them was perforated into the basal cistern, allowing the brainstem to get into position again. But there's still, when you look at the post-op image, there still seems to be a significant component of that arachnoid cyst, Venkat. What's your thought on that?
Well, I think it'll be interesting to know the recent MR after he came back with endocrine deficiency to see how the cyst behaved.
Casper?
and at surgery, was the basilar artery seen clear of arachnoid, or was it not seen?
So I wanted to briefly again bring up the stereotactic techniques to shunt internally from arachnoidal cysts. And I want to show you briefly on my screen, if I may share that, why I think that's a smart idea, because a shrinking arachnoidal cyst after fenestration will condense the cyst wall and has a higher chance to reocclude and then refill. So in the literature, there's ample evidence that up to 40% of fenestrated arachnoidal cysts will reclose and reaccumulate depending on where the cyst is located, and how big your fenestration is. But I want to show you briefly, if I may, one case that I presented at my last meeting, which was also in the PFOS. Oops. This one. And
One second, I think we have a technical problem. Yeah.
So my argument for
someone else is sharing.
That's me.
Someone else is sharing screen.
All right.
Can you close the screen, please? I need to complete this 2 minutes.
Okay. Let me close it.
So I could see the basilar artery clear right from
Let me briefly just want to show one picture of this. So this was the initial problem, and here's the arachnoidal cyst that sits, in this case, supracerebellar and posterior.
We've got two
I think Prof. Venkatramana still hasn't finished, so I think we just...
So
I apologize.
This is the scan of the 15 years.
Yeah.
This is the MRI scan, which shows possibly some reocclusion of the, communication that has possibly happened. So, but still, you could see the clear, between the lateral ventricle and the cyst, there seems to be a very good communication. And from the cyst to the prepontine cistern, there is a communication. So, but still the child has come with the symptomatic. So we decided to go back and take a look at that. And this is what it is. There is a small hole, and probably not sufficient enough to drain the CSF adequately. So this time we went back again and enlarged the opening again. So that's the reason probably it was partially functioning.
Did you go through that and look at the distal end of it, Venkat?
I resected a bit of membrane there, which is very thick. So, and also coagulated the membrane to make the opening slightly wider. and child became completely asymptomatic after that. So I will continue further.
I'm just wondering whether you put in the scope further in through that ostium and saw what was on the distal side of it.
Let us see how it is, because usually you see the whole anatomy.
So we need a long-term follow-up, especially in the prepontine suprasellar regions. They can present with significant morbidity due to hypothalamic and endocrine dysfunction. That's number one. Number two, a partial or a total occlusion of the initial cystocystonostomy can happen, which can be the cause of recurrence of the symptoms in these children. Thank you.
Venka, just one question again. Have you went with the endoscope into that opening and you see a huge area, and then went all the way down along the clivus, all the way there to the, and you have also opened there?
Yes, it was a huge place that the other membrane down is also open right at the first time itself.
Okay, because that is essential for these, at least for these suprasellar arachnoid cysts. You need two openings. If you only wake the superficial opening, that the high chance of closing, and actually also by blind shunting.
What I've shown,
you shunt this. It's too thick to do that. Okay, that was very nice.
Okay, you want to unshare so that we can see Casper's presentation now on his argument for not fenestrating and putting in a stereotactic catheter. Is that right, Casper?
Yeah. So just want to show again this one case of a, in this case, supracerebellar arachnoidal cyst. And my old mentor, Christoph Ostertag, has published a series of 28 of these in various locations across the brain. Here, the idea is in a fixed stereotactic ring to place a Holter ventricular catheter with slightly enlarged holes and drain internally the cyst content after aspiration into the next ventricle. So if you do this well and you do pre-surgical fusion images, you get a Fiesta T2 and the CTA, you can avoid any vessel next to this. You leave the catheter tip with larger holes in the cyst and you drain into the decompressed ventricle. This never closes. This has worked 100% of the time, and this is how it looks over time. The pre-cerebellar arachnoidal cyst shrinks, and after a year, it's completely gone. And this operation takes you less than an hour. There's no manipulation. There's no risk. I really think it's just undervalued because we are all afraid of doing it blindly. But with modern imaging fusion technologies, the risk is minuscule. And I honestly think one should consider this instead of going in with a mobile endoscope and all the associated risks of manipulating two ends of the cyst that need to be fenestrated, as Andre said. Thank you.
You're obviously doing this with neuronavigation, right?
Yes.
But you are right, Eckhart. The supracerebellar cyst is impossible to find this second area. You only can make one opening. So they have they have the higher tendency to close. And that's the same with the temporal arachnoid cyst. If you only make a small, with an endoscope, make a small opening between the oculomotor nerve and the carotid artery, that's all, you will fail. You need to go through 3 layers all the way because of this cyst wall. Then you have arachnoid, then you have Lilliquist membrane. So you have to make multiple openings to have and establish a clear flow. And that will maintain. And therefore, this is a nice indication. I agree. But I don't know if that is a sharp opening. Some of these cysts are so tough to perforate. Because for my residency time, we know when we tried bilateral shunts and we tried to shunt the suprasellar arachnoid cyst, the catheter would just bend off that cyst. It would never enter blindly.
Well, I don't agree with this 100%. Going through 3 layers with the stereotactic without 100% without a risk cannot be on a near midline structure. That risk is still entailed. There is a percentage, and you can have it. It doesn't mean one case does not make a series. And if this has been the regulation, stereotactic has survived as #1 indication for this cyst. People refuse to the endoscopy because they can puncture it under vision. This is the most important part, not to do it blindly. This is the indication. But it depends on the location, as I said. I mean, a temporal one is very difficult to get rid of it. And perhaps this is an eccentric one, can be done with the endoscopy. But this is not without risk. It's just for the sake, this is an educational webinar for young generation. They think now that stereotactic is the sole indication for these cases. And it's not endoscopy.
No, that's not what I meant, but it's a minimal invasive, and in the hands of an experienced surgeon, you can make this work with an implanted catheter that keeps the opening pain, and there's no reocclusion rate,
Well,
which in
the
itself
definition of minimal invasive became very loose, I think, in general, not for you, but it became very loose. Everyone wants to sell something, you say it's a minimally invasive. I want to know the safety. This is an essential part of the minimal invasive procedure at large. And that's what I feel. Endoscopy, it is the same. This is the minimal invasive in the sense it's a borehole and it's a needle. But the rest carries some complication. We have to be aware of it. It's they all have expert, and you have the values to fuse these images and to make sure that the MRA and the CTA done. And you make sure the bridging veins not on the way. They are structure, you don't see them very well with these images even, and you got hit them. And that's why I feel this is not without risk. This is the message I want to say. This, we still use the endoscopy, but not without some risk.
Okay, with that note, I think we're able to close this session of the webinar. We go to the next session, and I hand over to Vladimir Benes and Chandrasekhar to lead us through the second session, please. Vlad?
Thank you, Mudri. Let's just go ahead since we do not have time. So the first presentation is by our good friend Igor Lima Maldonado from Tours, and he is going to talk on the nose and paranasal sinuses anatomy. Igor, are you ready?
Yeah, I'm sharing my screen. Thanks, Vladimir.
Go ahead, you have 15 minutes.
You see it?
Yes, sir. Okay.
Okay, so good afternoon. It's for me great honor to participate in this webinar, and thanks for having trusted me this task. We'll see the main anatomical concepts related to endoscopic approaches. In many ways, the anatomy is the same we're used to, but the angle of view is different. So we see cadaveric dissections related to the nasocranial and intracranial stages in function of the angulation of the endoscope. So just a short history before studying the anatomy of endoscopic approaches is like looking at something after a corridor. I'd like to tell this curiosity. The tourists in Rome discovered that looking through the correct keyhole of the door of a specific park, which is the Knights of Malta Garden, offers a nice view of the St. Peter's Church there. And through a beautiful corridor of trees, as you see there. But if you go a little forward towards closer to our target, we can see more of the surrounding structure. So the angle of view widens as we approach. And finally, when you get to the end of the tunnel, you have a very wide view with a clear notion of everything that is around and we can visit. So anatomy for endoscopic neurosurgery is like looking at the St. Peter's Church. Our target is there, but the lateral elements may obliterate the vision. With the endoscopy, we're beyond the narians and there is no speculum, so the vision is panoramic. We are not only seeing the structures from another angle of view, but we are always also seeing structures that we are not used in the past. So the fact that we are exploring new areas made us to be more aggressive than with speculum. It's also a matter of illumination. Having the source of light closer to the target and not outside of corridor removes most of the shadows, even in the corners. And the structures are well visualized, but with some barrel deformation. So everything that is in the periphery tends to be drawn or look smaller. So the nose is our main corridor and would have done just as we would have done for the tree. So when you look inside, we see the nasal septum made up superiorly by the perpendicular plate of the ethmoid bone and inferiorly by the vomer. Of course, in the fresh or living cadaver, we will also have cartilage. We see the inferior and middle turbinates with the meatoses, and the middle meatus, you note that the turbinate presents an anteroposterior extension in its lateral side, which fills part of the cavity. This is the uncinate process. And behind the uncinate process, we will find a prominence, which is the ethmoid bulla, which is aerated and often removed for access to the anterior skull base. And so bone removal in this region, removal uncinate process, for example, will expose the ostium of the medial wall of the maxillary sinus here. And this uncinate process and the bulla, they make the space in the middle meatus very narrow and curved when they're covered by mucosa, which is called the semilunar hiatus. So if you look up, you will see the superior turbinate, there is sometimes a supreme, and when you follow the perpendicular plate and the vomer, we'll have really a narrow space closer to the middle and superior turbinates. Of course, it will lead us to the anterior cribriform plate and more posterior to the anterior wall of the sphenoid sinus. But when you follow more inferiorly, you have a wider space, and you keep following, you pass by the sphenoidal sinus, and finally to the transition of the clivus. So it will bring you to the upper edge of this opening, which is the equana. So if you follow the inferior turbinate or even the floor of the cavity, it's going to take you directly to the equana and the posterior wall of the nasopharynx. So let's take a look at the septum. We can see the relationships between the limits of the equana with the sphenoidal sinus and other elements of the skull base. Each ostium emerges medially to the superior turbinate in a narrow space, which is called the sphenoethmoidal recess. It lies approximately at the transition of the upper and middle third of the distance between the anterior skull base and the clivus. Penetrating the sinus then, or widening the ostium, will be much closer to the anterior skull base than to the posterior. It can be done relatively safe if the goal is to get to the sella. And we note that in this case, at least a quarter to a third of the superior portion of the clivus is the level of the sinus, and the rest remains inferior to it, but it is variable. So if we follow the soft palate, we see that our field of view goes as low as the transition with the oropharynx. So we can get as low as the upper cervical spine. So this is the anterior arch of the atlas. This is the odontoid process. For sure, we'll also talk about the nasal flaps or other types of flaps today. So let's take a look at the septum itself. You'll notice that close to our working region there, we see some vascular reliefs there. It's this sphenopalatine artery that emerges from the pterygopalatine fossa. So the posterior lateral wall of the nasal cavity of this region is made of palatine bone. That bone has a horizontal plate that forms the posterior portion of the hard palate there, and a perpendicular vertical plate. And the top of the vertical plate has two processes, like a bifurcation. One is orbital, and the other is sphenoidal. And in between, you have the sphenopalatine foramen with the artery. Usually, we don't see the foramen, but we may see the artery. So this artery gives a long posterior septal branch to the lower portion of the septum. The upper portion receives contributions from the anterior and anteroseptal artery, which is branched of the anterior ethmoidal artery, also contributions from the posterior ethmoidal artery, and anastomosis are frequent in this region. There is an area of rich anastomosis, which is found in the anterior portion of the septum, with the greater palatine artery and superior labial arteries, which is known as the Kieselbach plexus, and it's prone to traumatic epistaxis. If you look at the lateral wall, we have, again, anatomical relationships. Now with turbinates, meatoses, and different orifices, we sometimes see first prominence here, which is directly to the inferior meatus. This is nasolacrimal duct. The inferior meatus extends posteriorly and leads us to the torus tubarius and the nasopharynx. So this is the opening of the Eustachian tube. It means that if I follow the inferior turbinate, or the angle between the septum and the floor of the nasal fossa, I will go straight to the choana. So this specimen has the middle meatus quite open. Part of the bulla was open, so we can also see some anterior ethmoidal cells that open in the semilunar hiatus. Anterior ethmoidal cells usually open in the middle meatus, and the posterior ones open in the superior. And you see two large openings, one for the frontal, the other for the maxillary sinus. So medial to the superior, superior turbinate, we'll see a very well-marked sulcus, which extend between the turbinate and the septum. This is the sphenoethmoidal recess. In this recess, the ostium of the sphenoidal sinus opens in the upper portion. And the sphenopalatine artery will pass just superior to the posterior attachment of the middle turbinate. So let's take a look at the right nostril. So this or inferior, middle, and superior turbinate. We'll have the septum there and the ostium of the sphenoidal sinus in this sphenoethmoidal recess. Let's elevate the middle turbinate medially, and then you see the middle meatus covered by mucosa and the uncinate process and bulla. So we see the hiatus semilunaris with the infundibulum and the ostium for the maxillary sinus. And these structures can be well identified in CT. On the left, you have one window, parasagittal, and you see, again, inferior, middle, and superior turbinates covered by mucosa. The anterior wall and part of the cella are comprised in sphenoidal sinus and the upper portion of the clivus. And in the coronal sections, the upper one is quite anterior. We see the inferior and middle meatus. And in the middle, we see how the bulla is pneumatized. And if the uncinate process and bulla were removed, you have access to the lateral wall of the maxillary sinus and the delicate lamina that separates us from the orbit, which is the lamina papyracea. It's interesting to note also when we look at the roof of the nasal cavity that the cribriform plate that we see here is much narrower than the nasal cavity actually, and also deeper than the endocranial surface of the anterior skull base. So if a partial ethmoidectomy is performed with removal of uncinate process, bulla, and sonar cells, the approach is actually extended, and the whole width of the nasal cavity can be used to the basal portion of frontal lobes and olfactory tracts and related structures. So remember that the nasal cavity is very wide as the basal, but narrow at the top. It's also narrow in the anterior part and widens posteriorly. So a natural way to get to the nasopharynx is to follow the angle between the septum and the floor, and I know they will get to the choana. So if I'm lost in the nasal cavity, I just have to follow this angle and I will find the choana, tuba, and rhinopharynx. So if you look up, this space is smaller. you see the lower border of another structure, which is the medial turbinate, as you see here. Indeed, there is more space to progress the endoscope medial to the inferior meatus. We already see the posterior wall of the pharynx, the limits of the choana, and relationships with the septum. And you know that the sphenoid sinus will be up there. And if you look down, you see the Eustachian tube. Once we understand this anatomy, the anterior wall of the sphenoidal sinus can be opened. In this specimen, the septum was removed, and the elevation of mucosa allows us to identify the articulation of the sphenoidal rostrum with the vomer. So these are the lateral limits of the vomer alesis. And when the sinus is open widely, it allows us to discover structures that actually correspond to a different perspective of the structures we are using in cranial approaches. So of course we can check CT before for not for the general anatomy, but for individual anatomy, which is very important. For example, in case of lateralization of a septum, of the nasoseptum, or the presence of a lateral septum in the sinus. If you see it before, you orient yourself better. And then you see the relief of the sella, intrasinus and extrasinus portions of the clivus. And the lateral, you know that you have the paraclival carotid on each side. And we know that we'll have up there the cavernous portions of the artery. With this angle of view, we are actually indirectly looking at the neurovascular structures. So it's important to consider what is in the familiar side. First thing is midline. We have the planum sphenoidale, tuberculum, the sella itself, and the clivus. And then more lateral structures, the so-called lateral optic carotid recess between the optic nerve and the carotid prominence. If you see these structures, you'll know where the nerves are, where the artery are, where the cavernous sinus is. So we are here between the optic canal.
Igor, it's 2 minutes, Igor.
Okay, but past presentations were 20 minutes, 15 plus 5.
15 plus 5, okay, spend your 5, so another 7.
Oh, okay, thank you. If you see the structures, then we know that I have here the optic canal, and if I go anterior and lateral, I will find the superior orbital fissure in this region. So the lateral optic carotid recess corresponds to a bone structure in the endocranial aspect, which is the optic strut. And this represents the pneumatization of the strut and forms the floor of the optic canal. So if you take a look at these CT scans, you see how deep the pneumatization of the strut can be, and even reach the anterior clinoid. There are at least 2 different types of pneumatization of the clinoid. Can be through the strut, through the anterior root. In this case, you have a lateral optical recess, or a combination of both. The presence of a medial optic carotid recess, so medial to the artery, will depend on the degree of pneumatization of the sinus. When presented, it was described as a tear-shaped indentation that will take us to the where the lateral tubercular crest will meet the optic strut. So look at the carotid arteries. Also, we'll orient ourselves. We'll have the paraclival and intracavernous portions. So both genus will participate to the cavernous segments. We keep in mind that we have the 2 dural layers. One is meningeal and the other is endoischial, as you see there. And the cavernous sinus is developed between these 2 layers. So the medial aspect of the sinus, which will be there, has only the meningeal layers. In other words, it's formed directly by the sac of the pituitary gland. So there is very little tissue thickness between the gland and the artery itself. So the same structures are saying here. Lateral optic carotid recess, medial optic carotid recess. Cross the midline, I will find the intercavernous sinus, and we see then the anterior genu and the carotid collar with the proximal and distal rings, and then the artery will penetrate the subarachnoid space. It's interesting to note that the space between these two rings is larger medially, so there is a small invagination of the subarachnoid space that may be present medial to the carotid, with this the carotid cave. And laterally, a wider bonal removal may be necessary with removal of the structure, as you mentioned, the part of the maxillary sinus and artemoidal cells. And the section may even progress to the pterygopalatine fossa by removal of the posterior aspect of maxillary sinus and further exposing the clivus. And then you see there deep dissection of the cavernous sinus, and passing lateral to the carotid, the oculomotor nerve. We also see a very long nerve that comes from the bulbopontine sulcus, which is the abducens, and past the Dorellus canal. And both nerves will converge in the superior optic fissure. So what we see here is orbit and lamina papyracea. So if you had dissected up and anteriorly, it would be more, the planus sphenoidale and the ethmoidal cells. So we have here claviform plate partially dissected with still some mucosa and filaments. If you look down, you have the clivus. So this is an anterior border of the foramen magnum. So we're looking at the C1, C1 space. And in the intracranial space, which was the detail in the next lectures, we have a didactic systematization that has been proposed, dividing the approaches according to different regions and according to different portions of those bone structures that will be removed. We can have a different perspective and the different angles, find once again same structures we are using in the cranial anatomy, but in different perspective. So it's a very interesting, extremely rich anatomy. Of course, is still evolving because the indications and limits of endoscopic techniques are still evolving and being constantly redesigned. So it's not the end, it's just an ongoing history. Thanks for your attention. Thank you, Vladimir.
Thank you, Igor. It's then very short. Do you want to swap or shall I continue the next one?
You're asking me, Vlad?
Okay, so I will continue and I will present Ramesh Nair. Ramesh, up to you to talk on pituitary anatomy and approaches, please.
Thank you. Hope you can see my screen now. Can you see
yes,
my
screen? Yes, sir. Make it large.
Yeah, I'm actually a bit surprised that me and Igor prepare almost the same anatomy for the approach. But I think it's always good to see this anatomy because that never you can never get tired of learning it. And also each person's views perspective is slightly different, so I think it is useful. Essentially, Igor mentioned the way we approach the skull base. You have to look at the ways in terms of the sagittal plane and the coronal plane. And it's important that all these approaches are endonasal approaches. So the key component of many of these approaches is the fact that the key point is the sphenoid sinus. And above it, we have different approaches through the frontal sinus. It's a transfrontal approach, but that is limited by the nasal bridge and the brow. And in many occasions, one may have to reach up there. Then you have the transcribiform approach, where you approach like a small tumors or sinocranial malignancy or olfactory meningiomas through the cribriform plate. And then these are more common approaches to the sphenoid sinus, where you go through the transplanum approach or transtubercular approach mostly for craniopharyngiomas. And of course, the commonest approach is to the pituitary gland through a transcellular approach. And coming to the clivus, one could go to the upper clivus. One may have to drill off the upper clivus, the two dorsum sellae, and in certain cases, one may have to even lift up the pituitary to drill off that clivus in many cases of chordomas. And mid-clivus and lower clivus for other conditions like meningiomas and chordomas. And as Iger mentioned, one can go all the way down to the arch of atlas and even the upper odontoid process in many tumors. You can reach the anterior foramen magnum meningiomas through this approach many a times. And it's often limited by the angulation of your endoscope and the line you draw from the nasal bone towards the bone here, and also the horizontally you have limited by your hard palate. So that is in the sagittal plane. In the coronal plane, you have to decide up to what limit you can go. You can in the anterior fossa, of course, you talked about the transorbital approach. Of course, a supraorbital approach is also in the coronal plane. But in the middle cranial fossa, it depends on what structure you want to access. For example, there are many approaches accessing through the pterygoid, especially in the cavernous sinus and in the lateral sphenoid recess. Cases like tumors or meningocele coming from the temporal lobe, one may have to reach the transpterygoid, go through the transpterygoid approach. Even in some pituitary tumors, one may have to reach to the lateral cavernous sinus using a transpterygoid approach. And transcavernous approach, of course, you have to go lateral and medial to the cavernous sinus. And in the posterior fossa also, we have the coronal approach reaching the condyle or the petrous bone or the parapharyngeal area and the jugular foramen. So there is a wide variety of indications to add for all these approaches, and it's just to make you aware that there are avenues endoscopically to reach all these lesions, but these are only for selected cases. It's not that you can do endoscopy work, you can use this endoscope to reach all. There are other approaches, cranial approaches, which are more elegant in many cases, but there are very appropriate cases for endoscopic approach as well. This is the key point you need to know about these approaches. And we will not spend, but just to I tried to simplify it, even the speech mentioned about the endoscopic approach. If you look at the nasal septum, and from the side, you can see that the nasal septum is composed of a perpendicular plate of ethmoid bone here and the cartilaginous septum here. And in the back, you have the sphenoid sinus. In the front, you have the rostrum of the vomer, and the keel of the vomer is here. And the vomer bore extends all the way to the hard palate. And you have the two crusts. One is the crust of the palatine bone and the crust of the maxillary bone. And the lateral wall is more eventful and busy, as you've seen from Igo's talk, that you have the inferior turbinate, the lowest turbinate, and this is the first point of identification. As soon as you put an endoscope in, this is the first turbinate you will come to see. And then you have the middle turbinate covering the maxillary antrum and the bulla, and you have the superior turbinate. And this is an anatomy we need to know, and many units, including my unit, the END surgeons help you with the access for endoscopic approach, which I think is a very sensible way of doing things, because we cannot really keep following up all these patients in our neurosurgical clinic. Many of these patients after operation through the nose for skull-based lesions will have nasal-related morbidity, and some of them may need long-term follow-up, including removal of crusting and looking at the flap healing and all that. So ideally, I think it's good to have an END support. I know in many units around the world, it is done purely through neurosurgical route. And we have talked about the turbinates and the bone related to these conchae are often flexible and could be mobilized to get the access. And depending on what kind of tumor you're doing, you can go through one nostril or two nostrils. So uninadal approach is a very standard way of doing things if you have a selected cases of pituitary tumor. So large tumors, you often need binadal approach, often with 3 or 4 hands helping you out with that. And what about pituitary gland approaches? I mean, pituitary gland, we've been traditionally, as myself including, we started with transleptal approaches in the past, mostly microsurgical, using the microscope either through a sublabial route or an endonocal route. You go through the transseptal route. And also you can approach the pituitary fossa and the sphenoid sinus through the ethmoid without disturbing rest of the nasal structures. Or you can go transpterygoid approach, which I have mentioned already. And we will talk about the internasal approach, and you have seen it already from Igestor. So transseptal approach, I started off with this transseptal approach a long time ago, doing a sublabial approach, sublabial incision, and then go transseptally. Here you can also go an endonasal transseptal approach, which is what I did for many years using microscope. We incise the nasal septum, and then you dissect off the submucosal perichondrial layer, and then when you reach up to the vomer, you use the speculum to separate them, and then get into the sphenoid sinus by removing the nasal, keel of the vomer, which you see here. So that is the standard transseptal. You can see it is fairly less bloody operation than an endonasal endoscopic approach, but obviously you have to put in a speculum, or you may not need a speculum, but sometimes for bigger operation, the angulation and the manipulation of the endoscope may be a bit difficult when you have a speculum as well. But this is the standard approach which we've been following. But I'm not sure whether the trainees these days, especially in units where they perform endoscopic endonasal approach, are seeing these sort of approaches anymore. I'm sure in places where you use microscope, you see these approaches. And I remember in Zimbabwe, when me and Professor Imad Kanan were operating, Professor Imad Kanan made an incision just next to the, in front of the vomer to incise the septal mucosa, and then opened up so that is a variation to that technique, which I liked. Transethmoidal approach is mostly exposing this maxillary antrum, and then getting into the sphenoid sinus. So here the superior turbinate, the maxillary sinus here, this is the right nasal cavity, the lamina papyraceus here. So this is the middle turbinate. So when you resect it, the Curson punch is opening up the sphenoid sinus. So the eventual or the ultimate aim is to get into the sphenoid sinus in all these approaches. What kind of cases would you choose a transpterygoid approach? Maybe this sort of cases. This is a pituitary tumor which I didn't use the transpterygoid approach, but there are tumors which may extend lateral to the cavernous carotid artery, and one may have to go laterally. And also encephalocele into the lateral sphenoid recess, one may have to go through lateral transpterygoid approach. And there are many indications for transpterygoid approach, but for a pituitary tumor, only in very selected cases. So direct endonasal, which is more common and prevalent, and it's the direct route to the sphenoid sinus, straight into the sphenoid sinus without any other exposure anywhere else. But one may have to, depending on the extent of the tumor, one may have to disrupt the anatomy of the nasal cavity, especially turbinectomy, which is the one additional resection one may have to do to get a wider exposure. The view which is you see here is the view on the left side. So as you know, the lateral wall of the nasal cavity is all busy with the turbinates. As you see from here, the sphenoid sinus is straight directly towards you, just beyond the superior turbinate. The first view is this inferior turbinate as you view the nasal cavity on the left side, and then beyond that you see the middle turbinate. And as you go forward and then push the middle turbinate to one side, you see the superior turbinate here, and that is hiding the ostium in the back. So the one landmark which is always easy to follow the floor of the nasal cavity with your endoscope. As you reach the choanal arch, and the ostium will be about a 15 millimeter above it. So that is a very consistent landmark. As you know, we've been using navigation and intraoperative imaging in the past, but this is a very consistent landmark, unless the anatomy is distorted by previous operations or any other pathology like polyps. So once you separate the superior turbinate, this superior turbinate is often called the sentinel of the hiatus here. Once you separate it, you see the ostium, and that is your landmark into the sphenoid sinus. So once you see it, it's often customary in my practice is to open up a bit more before it gets all congested, and sometimes you might lose track of the sinus. And we have mentioned about the flap, which also has improved the outcome from the sort of operations to avoid complication related to CSF leak. And the one thing which I need to emphasize is that when the flap is harvested from the nasal septal mucosa, in the posterior part, one may have to limit your height of this flap to avoid damaging the olfactory epithelium. And beyond that, beyond the anterior end of the middle turbinate, you can go up, and also in the floor, you can go to the floor of the nasal cavity and customize it accordingly. So this is supplied by the branches of the sphenopalatine artery, as Igo mentioned. And the incision will be just above the coronal arch in the superior part, just to include just to avoid any damage to this sphenopalatine branch here. You have to incise it fairly superiorly, and you have to, for landmark, you have the ostium there. So the way to do is the subperichondrial or submucoperichondrial flap. You just dissect it without much trauma. And this is the left nasal cavity. The inferior turbinate is here. The incision is along the floor here. So you just need to dissect it, and then you can create a flap. Often some people use a monopolar, but also is equally useful to use a knife as well. So this is along the superior border of the flap. So once you remove it, you can safely, this is on the left side, I'm storing it in the left corner. So that's a safe place to keep it. And it's a personal preference which side you keep the flap. And in a standard pituitary, you don't need any flap unless you're operating a big giant pituitary which requires a repair of the flap, and if you're expecting a large CSF leak. And how is the flap helping you? This is a case with a large extension into the cavernous sinus, exposure to the carotid. The pituitary tumors extend in the carotid. So carotid was exposed. So I've used a flap to cover the opening, and the flap can be extended. If you this is not reaching it here, so ideally you should cover all the raw area to get a good position. So the thing to do is to release some of the connection, then you can pull it further, so that then it comes all the way up to the edges. So that's how you replace it. So once you've taken the anterior wall, if you open the sphenoid sinus on both sides, you can connect them and then remove the seal of warmer. Then you get into the sinus. And in some cases where you're doing a good exposure, often it's useful to take out the middle turbinate by just incising below the root, not at the root. Then just simply peel it down. So all the way down, and then just a small cut at the end, you will free up the turbinate. And you don't have to cut all the way closer to the base, because that might injure the sphenopalatine artery. Once you cut it, and then that piece of bone with the concha, sometimes that can be used as a free mucosal graft. So that can be a free mucosal graft at the end. Then you can remove the other additional bullae to get more exposure of the sphenoid ostium. The next step will be to widen the ostium. This is like a circular or mushroom punch, which the ENT surgeons are quite fond of. And then once you widen this edge, it's important that at the floor, the anterior wall, you shouldn't go too low down so as to damage the sphenopalatine branch. So always, even though you may not be using any flap, it's always good to keep the pedicle intact. We call it the rescue flap. Then once you have a rescue flap, even if you need to repair anything, you can often use it. So this is the widening which you have to be careful around the base to avoid damage to the sphenopalatine artery. Then you get into the sphenoid sinus. And this is, once you get into it, then you can connect the two sides by removing the posterior end of the septum. Then you get a wider view. And as I mentioned, this is not for all the pituitary tumors, but mainly for large pituitary tumors requiring wider exposure. You don't want your instrument, the endoscope, to clash with your instruments, which is called sword fighting all the time. But in most small tumors, unilateral approach is more than sufficient. The one thing which I need to make sure that you are aware of is the presence of a cell called Onodi cell. It's one of the posterior mode of cells, can become very large, and the optic nerve may be passing through it. So when you try to expand your exposure, be careful that there may not be much protection around the optic nerve. So one of the cases, this is a seller which I found very remarkable, that she did not have any septation inside. So you don't see that sort of seller. This is a very clean seller. You can see the optic nerve, the carotid impression here, the paraclinal carotid, the opticocarotid recess Iger mentioned is just lateral to it. And the medial opticocarotid recess is right here. And this is you can see the bone is so thin, you can see the pulsation of the carotid. The tuberculum cell is here, and the cell is here, the clival recess. The two paraclival carotids are on either side. This is the left-sided carotid impression. This is the paraclinoid carotid. And so for the cellar opening, you ought to open across the cellar. In this case, this is a hypophysitis for a pituitary biopsy. So you don't need to do a wider exposure here. And also the other thing which I need to ensure that this is a cutting burr in the middle. But normally when you use the drill, make sure that's the diamond drill. So don't use any cutting burr on that side. So the anatomy is already described, but just for completion's sake, I will mention this. If this is anatomy you need to be aware of. You have two carotids on either side, and if you remove all the bone, you can see how the carotid is. So carotid anatomy is the most key thing you need to be aware of, because this is one complication which you don't have to deal with when you're operating near a skull-based tumor. The carotid has a paraclival segment, and then it comes up, then it loops at the back, then goes into the cavernous sinus, and then again loops to become the clinoid carotid, and then goes intracranially. So if you look at this view, you can see these loops, this loop where the paraclival carotid becomes the cavernous carotid, the loop is coming medially. Same as here, the loop is coming medially. So all of the carotid is not in the same sagittal plane. They are deviating to one side. So here you have to go very laterally to get into the carotid. Here you are quite close by. So as long as you know where the midline is, so which is the most key point in this sort of exposure, you need to know where your landmark is. You may have a navigation, you may have other things, but all you need to know is your midline. If you know the midline, you know where the carotid is going to be, and then you've got to be more careful. All this blue lining is the sinuses, connections between the cavernous sinus, the inferior, the cavernous sinus, and the intercavernous sinus anteriorly here, and bilaterally you have the cavernous sinus. And with the bone, if you look at closely to one side, you can see the optic canal here, the lateral opticocarotid recess, and that's the landmark, as Iger mentioned, is the optic strut, from which you see intracranially, and the medial optic recess will be right here. And again, the lining of the pituitary gland is again the endosteal layer and the meningeal layer here, but so you know there is not much covering along the medial wall of the cavernous sinus. Often the pituitary capsule forms a layer. Whenever you operate on tumors, you will see a thin layer on the lateral wall. And often tumors extend from the pituitary gland into the cavernous sinus, between the separate compartments of the cavernous sinus, above and below the carotid artery. And you don't need to really do an additional transpterigod or additional techniques to get into that cavernous, and often you can follow. This case is a functioning tumor. This lady had hyper ovarian stimulation syndrome from this functioning tumor, causing FSH secretion. And you can see most of the tumor within the cavernous sinus. So often you can do this approach within the cavernous. So this is all the descended dome of the arachnoid here. We are on the left side cavernous sinus. You can see the carotid artery, which is delineated here. I'm into the cavernous sinus lateral segment. If you follow the tumor, and these sections are quite useful to get this tumor out from the lateral cavernous segment.
Ramesh, please.
Concluding now. So what my point is, all these approaches are there, but you don't have to use all these approaches, and you don't have to reuse endoscopic approaches for any of the skull-based lesion, but you need to select the most appropriate route for the appropriate case. So it's just that you don't have an endoscopic case, you have to use an endoscopic approach. Thanks very much, Vladimir.
Thank you, Ramesh. That was great. Both Igor and you. Let me give over to Chandrasekhar. Professor Deobjuare, are you there?
Yes, thanks, Brad. I think we have had wonderful talks by Igor and Ramesh, taking us to the pituitary. And though, as Ramesh just said, that we have gone through most of the anatomy, I'm sure Roy is going to tell us more and take us deeper into the anterior skull base with his next talk. Over to Roy.
You're muted.
I don't think I need to introduce Roy. Roy is one of our countrymen who's currently working in Switzerland at Lausanne. Would you?
Lausanne.
Yeah.
Okay.
Lausanne, and you are ready with your talk.
Thank you, Chandra, and I thank the organizers of both committees for giving me this opportunity. I knew and I'm glad that Igor and Ramesh talked about the endonasal perspective, so I focused my entire talk on anterior skull base anatomy and approaches, but then it's too vast a topic, so I will focus entirely on tumors and meningiomas of the anterior skull base. Well, this talk will be designed basically on neuroanatomy to help guide surgeons in taking the right call for these tumors of the anterior skull base. So the anterior skull base anatomy, as all of you know, is this region here, which is between the two clinoids. And the important structures here are the tuberculum, the chiasmatic sulcus, the planum here, and then as you go posteriorly, the dorsum and the clivus. And then, of course, if you put on the dura onto that, you find these interesting dural reflections, the falciform ligament here. Then you have the diaphragm ocelli here. And then laterally, as you go on, you have the cavernous sinus here with all the important structures. Endoscopic surgeons and transcranial surgeons treating tumors need to know a little bit about the anatomy of the vascularization of the dura of this region, many of which are from the internal carotid circulation and some from the external carotid circulation. And this diagram clearly shows you the arteries that are responsible for feeding these tumors that are often vascular. Now, if you look from the front through the endonasal perspective, you can clearly see these vessels that go on to the chiasma. And we're talking about tumors that essentially present or menace visual status. So attention to these vessels are primordial. And in 70% of cases, you will find that there are two groups of arteries, one group that goes behind the infundibulum and another group that goes anterior in front of the infundibulum to vascularize these optic nerves. And some of these vessels even go as far back as the hypothalamus. So these are crucial vessels that should be taken care of during surgery in whichever perspective, endonasal or transcranial. Now, just a short thing about nomenclature, very well-known information. They are classified into the olfactory group, the planum, the tuberculum, and the diaphragm. And as you go posteriorly, you'll find these tumors becoming smaller and smaller because they come to medical attention earlier. Some anatomical details. Interestingly, you all know that these tumors are limited by certain anatomical constraints, and these are the carotids on both sides. You have these arachnoidal membranes on either side that limit the spread of the disease. And so the tumor essentially spreads anteriorly over the planum, over the optic nerves, and above the chiasm around the anterior cerebral artery complex. So that's the preferential route of spread for these tumors. When you look at what are the results of the treatment of these tumors, it gets a little confusing because people group them very differently. So many of these are grouped in different groups, and therefore they are taken together. So literature is not that easy to identify approaches and also for the prognosis of this patient. But does it really matter? At the end of the day, the surgery is quite similar. And what you need to do is this, and on a long term, you need to make sure that the tumor does not come back. And of course, you don't damage the structures next to the tumor. Now, these tumors were classified essentially based only on size by Yazergil a long time back. But then skull base surgeons modified it to include classifications that looked at the arterial encasement and then and then also the brain invasion. So these important characteristics, arterial and brain parameters, should be taken into consideration for the evaluation of these tumors. This is our series. I'll just show you. We had published this some time back, and for planum and tuberculum, only that group. Most patients who come with visual deficits, and excellent results you could get with this with these tumors. Look at this lady with 63 years coming with a serious visual deficit. I'll quickly run through these videos because this is quite common knowledge. The key to the surgery is to keep the arachnoidal planes intact, because that protects you from the neural structures and the delicate arterial structures that vascularize the neural structures of essentially the optic nerve. These patients usually have a good outcome, and that's your tige, the infundibulum pituitary stalk that you see there at the end of your resection. And the outcome is usually good with visual improvement in the vast majority of patients. Another patient that you could see here, again presenting with visual loss. Your approach should get you close to the tumor, and without any Sylvian fissure dissection, you're right at, and hardly any brain retraction, you're right at the attachment of the tumor. So that's the beauty of these approaches. And one of the things that I will be dealing with later on in my talk in more detail is to make sure that you have the capacity to move the optic nerve. And that's essentially related to the clinoidectomy that we do for almost all these cases. So that allows you to move the optic nerve and allows you to have a good visual outcome when you remove these tumors. So if you look at our results, the way we look at these tumors, essentially tuberculum and planum, is that we almost always operate from the side of the involved nerve. And if there is no preference, then we go through the right side. It's always a basal craniotomy. Clinoidectomy in the majority of patients, it's always lateral subfrontal. And cisternal Sylvian opening is only when necessary, and that too only proximal. So we've had excellent results with our patients with the visual recovery in the vast majority of patients. Nobody had a visual deterioration, no major complications, but still you could have transient hypopituitarism. Two of them developed anosmia and one had a fourth nerve. One patient needed a recurrence, and that I'll show you later on. We do an endocrine function evaluation for all patients. Literature tells you that it's a good idea, because a good percentage of them can have pituitary dysfunction after surgery, especially if there is a large proportion of diaphragma sellae meningiomas in the series. So routinely that needs to be done. And then we come to these debatable issues based on the anatomy of whether you want to do a unilateral or a bilateral craniotomy. You look at literature, both are well described, but the recent literature says that in comparison, the unilateral approach has better results, but again, debatable. And when you choose a unilateral approach, how do you choose it? Now, there are publications that and authors that say that you should always do the non-dominant hemisphere to avoid these complications, but that seems like a very weak argument in my opinion. But there are anatomical factors that need to be taken into consideration. And one of them is what we are talking about is the unilateral edema of the lobe, which means that there is an asymmetric origin to the tumor, and the number of layers of the arachnoid here is only one and not two like on the other side, because the vessels are being pushed to the other side. So that you could see here. So essentially it would be better to come from the side of the major attachment and the side of the larger brain invasion, or at least brain edema. So that is one of the pointers that need to be looked at in these tumors of asymmetric origin. Now, if it is not asymmetric, where would you approach it from? And this is essentially for planum, tuberculum, and diaphragma sellae meningiomas. There are groups, many authors that say you should operate from the side of the worst vision. So This is mostly the situation in our unit, and essentially it's because there is a larger extension into the optic canal in these patients, and you do not endanger the contralateral optic nerve in these cases. But this is a completely debatable issue. Literature is quite divided on this, but the idea is to preserve the non-compromised optic nerve. So the answer is probably yes. However, I'll show you one case which recurred in which we used this philosophy of treatment. But finally, because this was the blind area of that side approach, we had a recurrence, a small recurrence on the medial side of the nerve, for which we went from the contralateral side and were able to completely remove it. So the blind area does exist. You can remove all the tumor, but if you leave some dural attachment not coagulated near the optic foramen, then that could be a problem. So the pros of the unilateral approach is that, of the contralateral approach, is that you have a direct view of the inframedial aspect of the compromised nerve. And the con is that you can possibly damage the non-compromised optic nerve. But these are considerations that could be thought about, should be thought about before deciding on the specifics of the surgery. Now, pneumosinus dilatans is something that occurs in a large proportion of patients with tuberculum cellae meningiomas. You see a large sinus. Now, Bill Caldwell's group did this very good paper that kind of classified the types of pneumosinus dilatans. And as you go down here, you can see that the tumor extensions vary. It's not always the same, and you will find some of them going behind almost to the clivus. Now, he looked at it from the perspective of the option of endonasal surgery, and it's interesting to say that it's only for type A, in which it does not go behind, that you can even think of an endonasal surgery for within the presence of a pneumosinus dilatans. Pneumatization of the tuberculum cellae is an important concept, and I think Igor or Ramesh touched upon this as well. This is a patient that we recently did that was essentially a tumor of the tuberculum onto the diaphragm, and if you look at the CT, you can see you have a free floating, not really floating, but a free optic nerve covered by thin bone around it with a wide pneumatization of the clinoid, the strut, and the tuberculum. So this anatomy should be clearly studied. And if you watch the video, you can see that it's essential that you go all around the optic nerve and get into the tuberculum, and you have to do tuberculectomy and a planectomy. And so that's your glimpse of the optic nerve within an aerated sinus. And of course, that the bone around the nerve has to be removed, otherwise you will not be able to mobilize the nerve in the intradural compartment. So that's an important consideration to see on the CT scan, and then plan your surgery. That will get you in the intradural space, the capacity to move that optic nerve, a very good access because you've drilled off the entire planum to be able to remove the tumor. And you can see the movement of the optic nerve. It's not that dangerous because you've completely liberated the nerve of all its bony relations. Right, so look at the post-op. You could see these are the pre-op images. These are the post-op images. You can see the resection of the tuberculum and the planum. Essentially on one side, you can see the entire bone around the optic nerve that's been removed. That helps in the mobilization of the nerve. And there you see your post-op images that show a total excision and complete decompression of the optic nerves intracisternally. When you study the anatomy of these tumors before surgery, it's very important to look at the bony anatomy, and that's why CTs are very important. And this, I would urge you to look at this publication that looked at the anatomical study of the prechiasmatic sulcus. And this area can be narrow or it could be wide. And then if you look at the angle that the chiasmatic sulcus takes, it could be a flat one or a steep one. So the interoptic distance, the planum length, the sulcal angle, and the chiasmatic ridge all need to be studied minutely before going on to surgery of this tumor. Now, this is a point that I thought we should address as well, because I've heard people talk about a large Sylvian fissure opening and operating these tumors through the Sylvian fissure. There have been some publications that talk about it, but look at their results. The visual improvement is low. There's visual aggravation. There are cerebral infarctions. Honestly, I don't think this is a great idea. And most recent surgical series show much better results with skull-based techniques. Just open the Sylvian fissure proximally, however much it is necessary, and that should be enough. Opening of the optic canal is another debatable issue, and many groups have said it is necessary, but some have said it's reserved for extensive optic canal extensions. And if you decide to do it, would you open the canal extradurally, intradurally, falciform ligament? There's no agreement on this at all. Looking at series, all are possibly acceptable in literature. But what it does is to give you rapid relief of the compression of the optic nerve. It elevates ischemia. It allows you to move it to access tumors in blind spots. So that is a yes for me. It should be opened, at least in the majority. For small tumors, maybe not, but tumors that go into the optic canal and larger ones, I would do it. Should you do it before or after tumor debulking? Again, there's no agreement in literature. Only a few people have addressed that. But logically, it seems smarter to do it before the debulking. Now, the most debatable one, especially in this combination of the endoscopic committee and the neuroanatomy committee, is what's the value of the extended endonasal approach for skull-based meningiomas? Huh? So there have been many groups with very good endoscopic surgeons that have said, even to the extent that in appropriately selected patients, they have better visual outcomes. Now, are they comparing apples to oranges? I suspect that's the case. But this is our series in which we had a patient with meningiomatosis, operated many times before for planum, meningiomas, tuberculum, and all over the place, came with a truly infradiaphragmatic meningioma. And that, in my view, is probably the best indication for an endonasal operation for this particular pathology. For all tumors that are supradiaphragmatic, I would be very hesitant to do an endonasal operation in my series. I'm sure, I know there are many panelists who are excellent endoscopic surgeons who would probably disagree with me, and let's see how the discussion goes. But that's the video of the case that we did, and we got a very good result through the endonasal perspective. What are the limits of extended endonasal approaches? These are groups that have a very good in endonasal surgery, and they have maybe the largest experience in the world, and they have evaluated their results and they found these are the limitations. Tumors extending lateral to the internal carotid and optic nerve, vessels which are inside and you suspect the dissection is difficult, are limits. And all of these patients require an extensive skull-based repair. But on the and in addition, what many endonasal groups don't talk about consistently is that there is a significant decrease in nasal quality of life in endoscopic meningioma surgery, and that's well known. And I don't think that is under debate. And this never happens in transcranial surgery. So that should be an important consideration for endoscopic skull-based surgeons who would like to treat the majority of patients with, of meningioma patients with endonasal approaches. Now, a very good study that actually tried to compare similar apples, if you wish, is this two groups known for transcranial and endonasal approaches who compared these based on a very minute, precise anatomical measurement, these tumors with their outcomes. And their finding was that tumors that were treated by the transcranial approach had higher tumor scores, which means that they were more difficult tumors to treat. The outcome was not very different, especially for vision. The recurrence rate was also not very different between the two groups. Both had about 10%. So essentially what the study showed that the more difficult tumors are treated by transcranial surgery. If that's the case, why would you subject an easier patient to an endonasal surgery, especially when you know that there is a serious nasal outcome issue? and if your results with transcranial surgery are good. So these are serious considerations that should be considered for meningioma surgery to decide between endonasal and transcranial surgery. I think I'll skip this video. I would just like to stress on the last point that I want to make is that the ophthalmic artery in tuberculum cellae or planum or diaphragm cellae meningiomas need to be looked at carefully. And look at this picture, that's the optic nerve, that's the ophthalmic artery. And this particular patient who came with no visual deficits had this widening of this space. And so the optico-ophthalmic space was filled with tumor. And that should be an interesting consideration, and I'll show you why. Just keep looking at this video. I'll quickly show you this. Now we removed the entire tumor except the part that's going towards the ophthalmic artery. And once you remove that part which is covering the ophthalmic artery, you see that it is going all around the ophthalmic artery and that we're removing that part. And then we finally come to a part which is on the other side of the ophthalmic artery. So this is the contralateral nerve, and this is the ipsilateral carotid here, and contralateral carotid and the contralateral ophthalmic artery. Now this particular region is not easy to do it because you have not done a clinorectomy on the opposite side. So the optic nerve mobilization will be limited. You can't really coagulate here if you have a bleeder from the dura, because then you would essentially produce a vessel spasm, or you would probably do thermal damage to the contralateral nerve. So this should be done with great caution, but if you're a little patient, you can keep removing it and try your best to avoid a coagulation, even if there is a dural bleeder, and maybe do some packing. And one interesting thing, because we have not coagulated the dural attachment in that particular place, we've just got hemostasis. What I would do is I would put a bit of fat between the nerve and the residual dura on the contralateral optic nerve, in case a few years later, if by bad luck he comes with residual tumor there, maybe radiosurgery could be an option. So chiasmospexy of or optic nerve neuropexy of the contralateral nerve could be an option in these difficult cases that go into the optico-ophthalmic compartment. These are the post-op images. I think it's a total excision. That's the fat that's covering the nerve. And let's see what happens in the future, whether there is a residue here. If there is a residue, I think that fat will stay. And we have studies now that show that the fat reduces in size to about 40% in 2 years. And after that, it remains stable. So we have a good chance that we'll have significant amount of fat tissue to help protect us from irradiating the nerve if we need to do it. Now, in conclusions, I'd like to say that the excellent visual and tumor outcomes are possible with transcranial approaches if a skull-base frontolateral approach is done with very minimal morbidity. But again, I don't want to be dogmatic in this issue. I think the choice of approach essentially depends on the surgeon experience. There's no sense to do a surgery in which you don't have too much experience. I would rather go for the surgery that you are good at and you prefer. But what I really want to stress with this presentation is that a very precise bony, tumor, neural, and vascular anatomy is mandatory to choose the right approach and to tailor the approach to be able to give you the best results. I would urge you to look at these two recent publications led by our group on behalf of the ENS Skull-Base Committee, that is detailing all the material that I have presented here on two anterior fossa or anterolateral fossa meningiomas, one on clinoid and the other one on tuberculum cellae meningiomas. I thank you very much, and I'd be happy to answer any questions if you have them.
Thanks, Roy. I think it was a fairly comprehensive review of the problems related to anterior skull base transcranial versus endonasal, and the anatomical facts of the steepness of the angle, and I think the sphenoid sinus, also the fact that you can probably have some advantages of a contralateral approach. I think all these we can probably discuss when we come to the discussion forum, because we are getting on with time. So I would request Sanjeev Jairatne to talk about the posterior skull base now, and then we go into the discussion. I'm sure all the panelists will probably cover these points when we come to the discussion.
Thank you very much. Are you seeing my slides?
Yes, yes, Sanjeev.
Thank you. I actually have a question for Roy, but I will save it, Roy, for when we come to the discussion. So I've been asked to talk about the posterior skull base and the craniocervical junction, anatomy and approaches, and that's a big topic for 15 minutes. So I'm going to go in not too much detail at all, really, into some of the approaches and some of the concepts on and my views on the skull base and the choices between the open and endoscopic approaches. So this is the sort of thing, you know, we all have to deal with. A wide range of tumors. You can get quite, bottom left here, quite vascular tumors. You get tumors that invade the brainstem, tumors at the craniocervical junction, more straightforward petrous tumors. The far right are soft, this is a chondrosarcoma. The others are meningiomas, vestibular schwannomas. And these are the sort of things that we have to deal with in the posterior skull base. And there's quite a bit of difference in opinion about endoscopic and open approaches. So I think I'll be very clear. My view in the posterior skull base, except for the petrous apex, is for large tumors like this, I favor open approaches mostly. Now, the one exception are soft tumors like chondrosarcomas or chordomas. Then I will look at endoscopic approaches, but by and large, I favor the open approaches for most things in the posterior skull base. But my view on whether we're going open or endoscopic is that actually a lot of things don't change. And I find it quite surprising sometimes when you watch residents or things operating, that actually the technique changes dramatically when they go endoscopically compared to an open approach. And I think it should be done exactly the same whether you're going open or endoscopically. So some things cannot change for skull-based tumors. You're still using sort of this bimanual dissection technique. You're still respecting the arachnoidal planes. And that doesn't matter whether you're doing this sort of bottom right here, far lateral or endoscopic approach to a foramen magnum meningioma, or you're taking out this sort of chordoma that's going to the cavernous sinuses and going back to the brainstem. I think that's the same. And I think the exposure has to be adequate, and we've heard about that nicely in all of the previous talks. And I think one mistake people make in endoscopic approaches is that maybe we're not as experienced at getting that big exposure, which I think is very important, as we would for an open approach. And whether it's open or endoscopic, you know, getting a good repair is key. You want to prevent CSF leaks and things like that. So some things don't change. But some things I think are very different. And that really plays to how I decide on what I'm going to do in the posterior fossa. So almost all of the tumors I do in the posterior fossa tend to be large. They're smaller tumors. I think you consider an endoscopic approach. But for me, for these large tumors, particularly meningiomas and things, I favor an open approach. And that's partly because I think for the tough tumors, actually, or there's brain invasion or invasion to cranial nerves, vessels, I think that's much more challenging endoscopically. There are clearly advantages. You know, you will take the dural layers and things like that. So you're getting a true microscopic resection of these tumors when you come endoscopically because you're getting to their origin. The other big thing for me has to do with bleeding. And I've had at least a couple of occasions over the years where we've had severe bleeding from the carotid or carotid injuries. And for me, they've been open, and actually being able to control that, I think, is a lot more straightforward open. We're very used to putting clips on from our vascular experience and dealing with that. And although it's stressful, I think it's a lot less stressful than when it happens endoscopically. And I've been called into situations with my ENT colleagues when we've had bleeding in the carotid endoscopically, and you can really feel locked out, I think, sometimes with endoscopic. So for me, if there's going to be quite serious bleeding or particularly vascular tumors, again, I would favor an open approach, I think, or invasion into blood vessels. I think you've got a lot more control there. So that's sort of my view, although I heavily favor, for a lot of particularly sinonasal tumors and things like that, I favor endoscopic approaches in the anterior fossa. It's very different in the posterior fossa, barring the petrous apex. So approaches to the posterior fossa. So you've probably seen me show this picture before. It's from the Roton collection. And I think this picture shows us a lot of what we need to understand about how you would approach the skull base in the posterior fossa. So there's obviously a view posteriorly. The brain and brain stem have been removed. We're looking from the back. You can see the vertebral arteries coming in at the level of foramen magnum. You've got C1 here. You can see the cranial nerves and the basilar there. And important, some of the important nerves, of course, to understand is where 6 and 7, 8 are, and the trigeminal. And then based on that, you can start to decide what gets you where here. So let's start with the petrous apex. So for me, the sort of anterior petrosectomies, and I know people go a lot lower than this, but I don't think you can safely get, particularly for tougher tumors, below the level of the IAM. So I use it purely, I'd use an anterior petrosectomy purely for tumors in that location, with some degree of splitting into the layers of the cavernous sinus. Retrosigmoid, I hugely favor, fantastic approach, and use that a lot for the skull base and the posterior fossa. I think it's a real workhorse approach. I'll talk a little bit about each of these approaches, but I hugely favor this one. And of course, when you come down to the foramen magnum, you're looking at a far lateral approach, and we talk about whether it's far lateral and off lateral. We can discuss that a little bit. And I'm just talking on the open approach, so I'll come to endoscopic in a minute. And of course, then there's the one I've talked about before in the committee. What I really like, I like sectioning the tentorium and drilling out and doing anterior and posterior petrosectomies and coming around for lesions anterolateral to the brainstem. The one approach I don't talk about, but I must mention because Roy and Vladimir here, is the supracerebellar approach, which they both use very nicely, which I don't use commonly. I like this slightly more aggressive approach and drilling out of the petrous bone to get around. So those are the sort of major open approaches, was one additional one I mentioned there. And then there are variations of this that you can use in getting around. But really, you know, most of this work actually you can do with a good retrosigmoid craniotomy. And I'll talk about the endoscopic approaches and come back to this picture again to look at both sides. So let's look at briefly at and I'm just going to talk a little bit about each. I'm not going into a huge amount of detail. Let's talk about the retrosigmoid approach first. I think this is, as I say here, is the foundation to everything you want to do in the posterior fossa, and whether it's straightforward cases or this is probably one of the most challenging vestibular schwannomas I've done. This picture on the right here is incredibly vascular tumor in a 19-year-old. And you can see you can get very nice resections. There's a small bit left there to protect the nerve. He's got a House Bregman grade 2 post-op, which is now improving, so should return back to normal function. So even extremely challenging tumors, you can very safely remove through a retrosigmoid, and you can do almost anything if you really wanted to. We like to talk about some of the more complicated approaches, but actually I think this is a real workhorse approach. As in this case, it was a very tight young patient. You can come down, open foramen magnum, do whatever you need to do, even combining with other approaches coming anteriorly. I know we have a lot of quite junior people joining us. There's a lot, you can spend a lot more than 15 minutes talking about just the retrosigmoid approach, but I think when you're starting out, the really important thing to understand is your craniotomy must be tight to the transverse and sigmoid sinuses. It's really important to drill this location here. It gives you a nice view towards the jugular foramen, and do open nice and low. It allows you to get into cisterna magna and drain. You can use a bone nibble or whatever and drain CSF nicely. And then you can do any of these cases I'm talking about. And it gives you a fantastic panoramic view. This is just the anatomy here. You can see 5 is deeper. You've got 7, 8 complex, 9, 10, 11 going to jugular foramen. So fantastic panoramic view into the CP angle, and you can do a lot of work with just this approach, and a good place to start. As you come lower down, you have this, now you can see here foramen magnum, and you see this tumor at the level of foramen magnum. Usually this slide here is just to show the 6 and 7 nerves, usually reaches to about that sort of level, and you're working quite low down in the CP angle and foramen magnum. And we use this term enough lateral, and I think that's correct. If you look at the picture actually, and then once you've drained CSF, you see that the tumor has made a lot of the has done a lot of the work for you. I think it's very different in vascular work. If you're clipping a pike or something, you may want to drill the condyle more. But actually, for tumors, they've made a lot of the work, done a lot of the work for you. So we talk less about the far lateral and drilling of the condyle, and this concept that Vladimir likes to talk about of the enough lateral, where actually it's the positioning, the head positioning, getting the muscles out of the way, exposing down to C1. You don't actually, and exposing towards the vertebral artery, but you don't actually have to drill a lot of the occipital condyle in tumor operations, because the tumor has displaced the structures out of the way for you, and you can get very nice view in. So just with good positioning, understanding the anatomy of the vertebral, you don't have to drill, as in anatomical dissection, you don't have to drill the condyle in an extreme manner. It's just about getting these muscles out of the way. either in one layer, or I like to split them, whichever you prefer. Understanding the anatomy of the suboccipital triangle and how the vertebra lies between rectus capitis posterior major and the obliques. You get into a very nice view here. This is the tumor. And all of this, a lot of this is done really with just with positioning and getting that exposure, not so much with drilling of the condyle. And then you can see here's nice arachnoidal planes. Spinal cord is here. Brainstem is here. You can follow this in and get very, very nice resections. So foramen magnum, whether it's quite lateral or more coming around more medial, enough lateral, far lateral, it's a good approach. Then this is an approach that I talked about before, so I won't go into too much detail, but when it's lesions are anterolateral to the brainstem, I really favor this. I like doing the anterior and posterior petrosectomies. I like cutting the tentorium. I think it gives you this really nice, this is just intraoperative view on either side of 5, and you get this beautiful working space above the trigeminal nerve. Once you cut the tentorium, you can go forward, open into Meckel's cave. I really like it. The one big disadvantage, of course, is you can't really see below 9, 10, 11, below the jugular foramen. So you usually have to combine it with a retrosigmoid approach to look lower down and also to drain CSF initially. But this is the next big approach into the posterior fossa. There are variations. Don't have to do as much drilling. As I said, Vladimir and Roy really like the supracerebellar approach. Do the same thing. And then there's the petrous apex, and this is the one area where I really I do favor endoscopic surgery or open. It depends on the pathology. So top right picture here, I got a meningioma. It's not too hypointense. I expect it to be quite a tough tumor, and here I favor an open approach to this sort of meningioma. But the pictures on the left, this is a petrous apex cholesterol cyst. And this, of course, is going to drain very easily, very nicely. And, with a bit of drilling here, medial to the carotid, you'll get a fantastic exposure into it. And although it goes a long way down, as you see here, actually, we did the whole thing endoscopically, and it comes out very nicely. And then you have these sort of lesions like this. This is a chondrosarcoma, which is wrapping around the carotid. And if you can do one or the other, I think they're both very reasonable, or even combine the two. Depending on your expertise and skill level. So a sort of nice anterior petrosectomy will get that out nicely. Depending on your endoscopic skill level, you could consider coming endoscopically for this or combine them. And whatever you're going to do, you have to understand how the superior petrosal sinus, inferior petrosal sinus, particularly Dorello's canal, for a lot of these petroclival fissure lesions, and tentorial anatomy, especially if you're coming open for this. And probably the big thing you really have to understand at the petrous apex is the carotid. So this is that same tumor again. This is an anterior view of the carotid, and you can see how it's wrapping around the petrous carotid, both anteromedial. And so again, depending on your skill level, you may consider taking some of the medial parts of endoscopically, coming for the lateral bits open or completely endoscopically. It's all very reasonable depending on your experience, I think. So I've spoken about this before. I won't go into too much detail, but you have to understand the Kawase quadrangle there. The cochlea is here. Here has been drilled down this specimen. You normally want to protect the cochlea, but you have to understand how you split the layers of the cavernous sinus to reach this layer. The anatomy, the 7-8, I think, is the lower limit of what you can get to. How you cut the tentorium to get intradurally superior petrosal sinus, inferior petrosal sinus, and the 6th nerve running over that are all the sort of important anatomy to understand whether you're coming open or endoscopically. And what's really important for both, of course, is carotid anatomy, particularly if you're coming endoscopically. My colleagues have already started to talk about carotid anatomy, but I think if you're going to do tumors in this location, you've really got to understand carotid anatomy. What are some of the key structures and landmarks, particularly when you're planning the operation? For me, one of them is the petrolingual ligament. It marks the entry of the carotid into the cavernous sinus. The dural ring, of course, is its exit. And so when I'm thinking of it, I like to divide it up. We have the segment here of a lastrum, which you can see. These structures are very easy to see on CT scans. You may want to use navigation during the procedure. Then you have, in your head, you have to picture the petrolingual ligament and how the carotid starts to siphon within the cavernous sinus. And this you have to understand either both open and endoscopic. We'll look in a minute to the endoscopic view of this. Sphenoid sinus is here. You're going to remember that as we come and look the opposite way as are the dural rings here. So this sort of understanding of this sort of anatomy, when you're intracavernous, when you're paraclinoid, And when you're paraclival, I think is really important, particularly coming endoscopically. And this is just a view, the same view again. So when you look at this, you must remember this. When you look at this, you must remember this. It's a nice paper from Juan Fernandez Miranda's group. And some of my colleagues showed similar anatomy before, but you have to understand again here, this is the paraclival carotid. The yellow lines mark it out nicely. So you've got paraclival carotid. Any of your approaches to the clivus, you have to understand that this limits you laterally. As you come higher up to lesions of the cavernous sinus, we saw some nice pictures of the cavernous sinus earlier in the anatomy there. And Igor had some nice dissections of the cranial nerves, the cavernous IC and then the paraclinoid IC, and how this relates to your lesion, and the preoperative planning is key. Then again, my colleagues have started to talk about this, but you have to understand that it's quite helpful to divide up the clivus into thirds. So you have the top third that Ramesh has already talked about, but it's essentially from the posterior clinoids down to sellar floor. So that's sort of, I should have angled it more, but that sort of level there. And there, the anatomy to understand is the cavernous sinus and IC on either side. As you get intracranially, third nerve, basilar earplugs. Moving forward, if you're really going to start doing clival surgery, then you have to understand is now from the bottom of the sellar down to the floor of the sphenoid sinus. So that's the middle third of the clivus. This is the bit where you really have to understand petrous apex anatomy, the carotid, paraclival ICA. So any sort of operating here, that is the key anatomy. And as you go intracranially, it's the distal sixth nerve as it goes into Dorel's canal and the inferior petrosal sinus. And the next bit of anatomy you have to understand as you start operating areas, there is this pharyngobasilar fascia here. Very, very tough, strong fascia, difficult to get through. You usually have to use a monopolar, really. I think it's best cut through and then separate it off before you can even get to the clivus. I agree with Ramesh, actually doing this with the ENT is helpful. They understand the eustachian tube, the fossa, rosemole, all of these lateral structures, and then pharyngobasilar fascia well, actually, in the nasopharynx. So actually very helpful at the start of the operation, even before you even reach the clivus. You find if you're doing this on your own, these are very, very tough layers. And it really matters when you're trying to do the lower clivus, which is really from the floor of the sphenoid coming down to foramen magnum. And this, I think, is quite, see another nice anatomical dissection is from the Roton collection. But this is quite hard, actually. You're bounded by petroclival junctions. And whenever you think of petroclival, you have to think inferior petrosal sinus, jugular tubercle, occipital condyle, lower cranial nerves, and the vertebral arteries are all intracranial when you're operating here. So I think this, again, for intracranial pathology is hard. For extracranial pathology, chondrosarcomas, chordomas, fantastic approach. Even if they usually have nicer arachnoidal planes, even as they breach inside, it's fine, but it gets a lot more challenging if you're doing large meningiomas and things like that. Endoscopically, certainly open, you're very familiar with that anatomy. So when you're planning these things, I think particularly if you're planning an endoscopic approach, I think you have to really understand what's limiting you. And for me, at the level of the clivus, it's really the paraclival carotids, inferior petrosal sinus. Is a beautiful view here of the sixth coming over the top of that into Dorel's canal. As you start to come lower down, it's the lower cranial nerves then. So I find this quite a narrow corridor, as I said. Most of what I do in this area are soft tumors, so it doesn't matter as much. You can work the tumor away with nice arachnoidal planes. I think for larger intracranial tumors, particularly tough tumors, I don't favor the endoscopic approach. I favor an open approach, and I think we've got very, very nice, elegant approaches into the posterior fossa, as we briefly talked about there. So just bringing it all back together, when you're faced with this, whether it's this sort of chordoma, as I said, big vestibular schwannoma, an relatively easy cholesterol granuloma cyst, or probably not too challenging foramen magnum meningioma. I think you really have to understand what each of these approaches gets you and where it gets you in the posterior fossa. It's the same when you're coming endoscopically. I think it's useful to try and divide up the clivus into these areas. Each of them have very good landmarks, like the Vidian canal here. This obviously rotundum, marking the floor of the sphenoid sinus in this picture here. And you can tailor, and actually sometimes I combined approaches. For certain tumors, if you feel some bits may be hard to get one way, I think it's very reasonable to do a combined endoscopic and open approach. Tumor consistency and invasion and things plays a big role when I'm picking. The experience of the team is important. I'm very lucky. I've got very good endoscopic ENT surgeons to work with. I've also got very good lateral skull base surgeons. So drilling out the Peters and things on the ENT side is very straightforward. And of course, what you're going to risk or benefit, what you're going to gain or lose in each of these approaches. So when I'm thinking about the posterior fossa, that's sort of my view on how I'm planning these cases. Finally, I won't go too much into this. Henry spoke about this very nicely. He had a nice talk, Henry Schroeder, showing how you can use angled endoscopes in the post fossa, whether it's in an MVD or looking into the porous in a vestibular schwannoma, or some tumors like epidermoids where the tumor doesn't really come to you. Looking around angles is very helpful. But I think be careful. You have to use very small diameter endoscopes. You can injure cranial nerves in your blind spots as you go past them. And again, like everything, it's about user experience in doing this. Okay, well, thank you very much. That's what I had to say about the posterior fossa. And I think for once, I've actually stated time, Vladimir.
Thanks, Professor Jairatne, for your excellent overview of the posterior fossa and CV junction area, and various points you made about the anatomical facts which decide our approach. There are quite a few young people who are looking for these tips, and I'm sure we have an excellent panel with Professor Grotenhuis, Dr. Kalungu, and Victor, apart from Vlad and Imad, who are our moderators for the day, who will be able to give us their views either through cases or their questions. Please, I would encourage the faculty, starting with Andre probably, to give their views either through cases or their questions and comments.
Thank you, Chandra. It's always amazing to see. You learn with every single webinar, with every course that I did over all the years. There are always little pearls that people can present, and those are based upon their experience. And that's one of the things. What we heard here, and I mean, this is, at the end, it is a webinar of the Neuroanatomy committee and the endoscopy committee, but the anatomy is the essence. And what you could see in all the talks that I heard, well, of course, initially from Dr. Maldonado and Dr. Ramajner, and of course we can say, leave it to the ENT surgeons to bring us through the nose, but we as neurosurgeons should also know what they are doing, or do it yourself, of course, but we should understand the anatomy. And that is what I think, because based on that anatomy, and that I like very much in the presentation of Professor Roy Daniel, is that showing all these little details of pneumatization of sinuses, the pneumosinus dilatans, indeed, a very, very interesting, and others showing the Onodi cell. We have to know this all. And that means anatomy is what we study, but the anatomy is before the surgery already shown to us by the imaging. You can't have enough of that. So it is your MRI scan, but also the bony structures. So I am a strong advocate of not only having a sagittal and coronal MRI for all the cases I do, I prefer also to have a thin slice CT of the nasal sinuses if you go to the pituitary or the anterior skull base. Because then you can really learn some details, and that's about not only the pneumatization, but you see a little bit of, in the meningioma cases, hyperostosis, and optical canal invasion. You have to decide if it is more on the medial side, that would be favor an endonasal approach. If it is lateral from the optic nerve, you will never get it through an endonasal approach. So these little details, and they can't be a surprise. And that is what I want to tell the younger people. They should not be a surprise during the surgery. Those are the things that you should know beforehand, because that is visible. And I know not everyone have the possibility of very highly sophisticated scannings. But if you look carefully enough to anything that you have available, you see asymmetries. You see, so all these little details, you have to watch that carefully. And that is what I like absolutely. And then that's the same again with Sanjeeva. You also showed it you emphasized the importance of planning, but also exposure. How you showed the retrosigmoid, this little trick. That lower part, if you drill that little tubercle there, that allows you much easier view of the jugular foramen. This is very little effort, but you have to know it before. And indeed, you never open the dura unless you see the sigmoid sinus edge and the transverse sinus edge, because these are the things that are essential. And going low enough, because I always told my residents, the moment you open that cisterna magna, you see the release of CSF, you won the case. Now it is, for the next hours, just dissection of the tissue, tumor removal of a schwannoma, and so on. But the approach, the structures, I mean, and therefore I like what you told about, because I know that Vladimir is in favor of not being dogmatic and saying, I always use far lateral approach. No, enough lateral means it is based on the anatomy of the patient. And yes, if you have a very thick neck, big muscles, obese patient, or a little child, which is much easier anatomically, pediatric neurosurgery is so much easier to do for us as neurosurgeons. But that means it is based on, it is tailored approach. It was your last slide, tailored approach. So open the anatomy for that specific patient. Either you go through the nose or you do an open approach. It is really carefully planning that. And if you have done that planning, the next day it is just executing your plan, and it will run smoothly, it will run fine. If you really look to all these details, and that is the same in open approaches as in endoscopic approaches. So no dogma about, I will always do a tuberculous cell meningioma from below, I will always do it from above. No, because that can't be true, because that will never fit the situation of an individual patient. So stop doing dogmas, study anatomy. Anatomy in the lab, but the anatomy of the patient before you finally, and then when you know the anatomy, you can position the patient in such a way that you can expose that anatomy. And that is what all these courses are about, that we drill our younger people to do this, because we have no standards, no standard ways of doing anything. It is individualized. And that is, I think, the most important lesson again from this webinar, that I have listened to all the talks, also the previous ones in the ventricular system. That is the essence.
Okay.
Chandra, that is my comment.
Chandra, Andre, you said one thing which is very important. Any dogma is wrong. It doesn't matter what is the color. Any dogmatic approach to anything in life is completely wrong. That's point number one. And number two, if you would adhere to dogma, you wouldn't have any fun. We wouldn't enjoy the neurosurgery as much as we do.
No, and exactly. I have to say that there is nothing better for your personal feeling and your ego than if you have done a proper planning and you have exactly seen that everything was as planned during your surgery and it went fine. I mean, that makes your day. And that's why, and I fully agree, dogma is never right, but it has been. I was raised in dogma. We always do frontotemporal for this. We always do retrosigmoid for that. It was And it is impossible. I never have seen a standard patients, not even identical twins. I once, in 1 week time, I had to operate on identical twins. The anatomy was not identical, not fully identical.
Perfectly right. Imad?
Excellent.
Imad?
You are muted, Imad.
Unmute yourself.
Imad, your comments, Dr.
can-
Kalangu's comments, I'm
Okay.
eagerly looking forward to that.
If you allow me in that context, first I'd like
Please.
to thank Roy for his fantastic review and publication. He put it all together in proper and objective way. Important, we should not be driven by trend only, because some of the procedure is driven by trend. Everybody is using the endoscope for this. I want to use it as well. You should be objective by the evaluation and make the proper judgment. And I like the word tailored approach to any procedure. No procedure is fixed in a stone. You have to tailor it accordingly. Sometimes you drill, sometimes not. I have a few comments on that paper, which is very nice. I am sometimes pushed by my own dogma, but I like to argue myself and challenge myself. Like drilling the optic foramina, I agree what you have crossed, but you have review it and then you made the decision. Opening before or after, although it's still dilemma, but I've been confronted. I used to do it at the end. My visual outcome was not tremendous in the first 5 years of practice. When I start doing it ahead of time, especially when you have tuberculum cell meningioma with the tumor tongue, and sometimes in both foramina, I found it much easier. You did the roof, the canal. You don't need necessarily to drill the anterior clinoid like in ophthalmic artery aneurysm. But if you open the canal, you can take that tongue that's usually coming from the medial part, and then you have a relaxed optic nerve to manipulate without ischemia or tethered optic nerve. This is one. Now, about that case with the edema on one side, and you favor that side, I myself, I will do what I think Pablo will do. I'll take from the soft side that is not affected. I'm not worried about that optic nerve because then I visualize it under my eyes and I avoid any manipulation on it and I counteract the contralateral side if it's tuberculum celli I'm talking about. But it was a wonderful presentation you gave with all bits and tools and ideas, and you fairly compare the two approaches decently. Thank you.
Can I have one little remark to Roy's lecture? Roy, we all understand that anterior skull base, but that's anterior skull base and middle skull base, because everything between tubercle and posterior clinoids, it's middle fossa skull base. Of course, we understand that. That's only that we are anatomical committee, so we should probably be precise.
One small point as well, from our experience with what they call it, osteopetrosis in the old days, we used to do bilateral optic deroofing from unilateral approach for marble bone disease for kids who was getting into blindness. And amazing, the distance between the two optic nerve is very short. You can very easily deroof the contralateral optic nerve and see that ophthalmic artery that you are worried about when you were showing the video. Thank you.
Thank you.
Dr. Jayaratne wants to, okay, go ahead.
Thank you, Imad and Vlad, for this. I didn't really talk about clinoid meningiomas, but it's coming to the edge of the anterior cranial fossa, and clinoidectomy is usually used for, it can be, in my case at least, I use it for most cases of anterior cranial fossa, but I take that comment. And thank you, Imad, for all the comments you made. But the case I showed in which you said of the ipsilateral edema, actually it's an olfactory groove and vision was not.
Oh, okay. Oh, I see.
Right.
I would say, Imad, the contralateral approach for olfactory groove, you go from the side of edema because then you can preserve the contralateral olfactory nerve.
Oh, for the olfactory, yes.
It's true in my mind for tuberculum cell. There you go.
Yeah, I was talking about tuberculum cell.
Contralateral side.
Sorry,
Dr. Jairatne wants to make a point, and then Dr. Kalangu, please.
Actually, my point was made by Imad. I agree fully with Imad. I think early decompression of the optic roof is the key. I'm sure for you, Roy, it's very straightforward to do a clinoidectomy for all of this. But I think for a lot of people who may be less experienced, just de-roofing the optic early. But I take your point. I think it's a really important point. You have to be able to move the optic nerve early, isn't it? It's a cause of problems. Yeah. Even draining CSF can cause a retraction on a tight.
You know what I do, Sanjeeva? I drill the clinoid, but I leave the tip behind because sometimes you have those 3-4 millimeters of carotid which is not covered by the arachnoid, and you could tear it, taking out the clinoid. So the last piece of clinoid I take intradurally when I'm inside and when I know what it's really about.
This is very good approach.
Yeah.
And I think
Dr. Kalangu, your comments, please.
I think there's been a recent publication on what they call hybrid clinoidectomy, in which the last part is not taken out. And it does not really need to be taken out in meningiomas entirely. I mean, I think Vlad is talking about aneurysms in which you need control of the both rings of the carotid. So in meningiomas, you just need to open the optic canal. I think, if I'm not mistaken, it was Matthias who published it, but they describe it quite well in that article.
Yeah, Tom and I spoke years ago. We think a lot of nerve outcomes are because people don't do that early on. But in this group, I'm sure that doesn't happen. I think everybody does it early on. But I don't know if Tom Santoris is still here. We thought of doing a study years ago.
I'm going to say that only dogmatics go and complete the clinoidectomy because what have it completed, yeah.
That's a minor dogma. The major dogma was orbitozygomatic.
Dr. Chandra, we have to give a chance to Dr. Kasati. I put him out.
Yes, Dr. Kalangu, your comments. Dr. Victor, your comments before we close.
Thank you. Thank you.
Unmute, Kasati. Unmute, yeah.
Dr. Kalangu, you are not, we can't hear you. Maybe you need to come closer to your mic.
Or
yeah, now we can hear you.
Or on the computer, higher up.
No, I don't think we can hear Kasadi. Maybe Victor can talk while Kasadi sort out the microphone issue.
Yeah, Victor, your comments, please.
F4, push F4.
Thank you. Thank you. Thank you. First of all, I want to congratulate all the speakers in this webinar. Lectures were fantastic. So we know that surgical anatomy of the paranasal region is extraordinarily complex, not only because of the anatomical variants of ethmoid cells, but also because of the proximity to the vital structures such as the cavernous carotid artery and the ophthalmic artery. I know of a case where one patient developed blindness due to ophthalmic artery injury. Because of I think there is a great variability, especially of ethmoid cells in this region. So the only structure that is always in the midline is the articulation with the bomber bone to the rostral part of the sphenoid. So if you go laterally, sometimes the bone between the cells with the carotid cavernous is very, very thin. So I think that's the reason I affirm that without good neuroanatomy, there is no good neurosurgery, especially for young brain surgeons. Neurosurgical anatomy is going step by step. And if you have the opportunity to make exercise, to develop skills to do a surgery, this is very, very good. For example, if you are going to make a transpetrosal presigmoid approach, it's much better for me to make the mastoidectomy made by myself, because I know where to stop this mastoidectomy in order to have a wide exposure to the petrous bone tumors. I don't know if you have an experience or if you have heard about these transoperative accidents, like the lesion of ophthalmic artery.
Thank you. Dr. Kalangu, you would like to say something? Is your mic sorted out? Yeah, please go ahead. No, we are unable to hear you, Dr. Kalangu.
One thing more, please.
Yes, Victor.
I saw a picture that Dr. Roy, I don't know, I don't remember. In this picture, the Labé vein is going in front of the intersection between transverse and sigmoid sinus, but that is not usual. The most usual is to find the Labé vein 1 centimeter behind the intersection between transverse and sigmoid sinus. That is an unusual variant, the picture that today I saw in the lecture. So it is for us is very useful to know variations, not only the usual anatomy, also variations. So I think we have to work in doing some statistic in these variants. So thank you very much.
Dr. Takeshi wants to make a comment, and then I think we have to close.
I'm
no,
Dr.
you have to.
Dr. Takashi Kon from Japan. Thank you for adding me. We have less experience of the endonasal approach, but we should learn to decide operative indications. So we have to learn from scratch. So we have to review again and again. So this is a good opportunity for me to learn. Endonasal, the clavicle chordoma is very few in Japan. There is a very less experience, so we should learn from the anatomy. But cadaver dissection is very, so many places done in Japan, but these days very few because of the lack of financial problems, several problems. So we want to learn more about the cadaver dissection. Thank you.
Yes, Igor, you want to say something?
Yes, thank you. Just a short message about this. One thing is cadaver dissection. The other thing is transpose the anatomy from the lab to the patient, and we talked a lot about individual anatomy. So I think about this issue, individual anatomy planning, we need the data sets of images. This is a nice, beautiful change from past generations because we are working with the data sets. Usually the data sets are with the radiologists, and we receive just the sagittal, coronal, and axial planes. This is basic. We don't want the basic anymore. We want to do reconstructions ourselves. Sometimes we have important anatomical relationships that are saying just changing the thickness of a slice, for example. So I think this is not a detail. We need to keep on working on this. We need to work with the data sets and do our own reconstructions, volume rendering, this kind of stuff is completely changing.
Yeah.
Well, final comments by Vlad, and I really want to thank the anatomy committee. Not only we learn the indications and the scope of our various approaches, we also learn their limitations, which are equally important. Vlad, your final comments, please.
No, final comments will be given by Imad. I just would like to say that lectures were extraordinary today, and that I believe that we all enjoyed all of them, and I'm pretty sure that we all understand that much more time should be spent beforehand with images than by surgery itself, and that we all should be doing the most precise work based on anatomy. Imad, up to you, please.
I just want to concur with you as well, conclude with you that visual rehearsal before the surgery, we all practice it by checking all the images and the tests. And sometimes we see ahead of time the potential complication and how we are going to manage it. And that's what we have to teach the young generation, to do this visual rehearsal. And I have to apologize for Dr. Kasadi. I tried to contact him, but it seems he tried everything, but we are not coming to this place. Perhaps the next time. I'd like to draw your attention. October, we will have a special webinar, perhaps one day only, for the honoring of Professor Bernard George, that we lost him a week ago after a struggle with sickness. So may God embrace him with his mercy and embrace him in heaven. And I'd like to thank everybody. Vladimir has been always the great supporter for the our committee. And we are looking forward, himself and myself, to have more collaboration with the endoscopy. We have, they are our kin in the practice. So thank you for everyone and have a good night.
All the best.
Thanks, everyone.
Just one.
Great seeing you.
Next,
No, the last
Yeah.
word's the last word.
on November.
Somebody wants to say who's talking?
Please. This me, Victor Hugo.
Victor, yeah, go ahead.
Next November, from 4 to 6, we are going to have a congress in Acapulco Beach. This is really a beautiful place to know. I know that COVID disease is still a problem around the world, but in Mexico is decreasing day by day, is decreasing. So if not possible to you for coming us, please, if you could collaborate with a lecture, we can work in a webinar in the Congress. But next year, I hope to see you here in Mexico. Every year, we are organizing this course, especially in Acapulco. So thank you so much.
Thank you.
Thanks, Victor.
Thanks, everybody.
Thank you.
Thank you.
Bye-bye.
Thank you.
Yeah.
Thank you.
Bye-bye.
Good night.
Bye.
Bye, everyone.
Bye-bye.
Bye.
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 Bye, Kasari, and all the others. And,
Kazadi.
Bye. We need to meet. I miss that.
yes, absolutely.
Sorry, we were unable to hear you, but maybe
Yeah,
some other time soon.
we have to lip read.
Thanks, Imad. Thanks, Pablo.
Thank you.
Thanks, Vlad.
Sandra.
Bye, bro. Thank you.
And
Andre,
Andre.
Roy, Igor.
Bye, Roy.
Hi, Chandra and Pablo, Casadi.
Asadi, hope to hear you soon.
No.